That working for everybody?
Yes.
Yep.
Okay, good deal. All right. I'm Taylor Roth. I'm an emergency medicine physician currently live in Mississippi. I am active duty Air Force. I'm stationed down here at Keesler Air Force Base with a ground surgical team. Did my medical school at Uniformed Services University in Washington, D.C., and then did my 3-year emergency medicine residency in Las Vegas at UMC. And that's kind of when I got involved with doing ski patrol. So did that for 3 years, kind of my own time, what little time I had during residency. And yeah, it was a great experience. So glad to see some people actually sign up to do the classes here. So, all right. So we're going to try to get through cardiovascular emergencies and OB/GYN/GU emergencies, which, this is like entire 5 to 8 year residencies dedicated to each of these subjects, but I'll try to condense it down into 3 hours. So we'll see how that goes. All right. So these slides are somewhat on the dull side, so I'll try to do more explaining based on some of the pictures, because I think most people learn better that way, and this is understanding anatomy and physiology is much easier if you can kind of visualize what's going on versus having me talk at you. So some of the things they want to get out of this lecture for some kind of core competencies here. We'll go over some arrhythmias, basic assessment of somebody that has some sort of cardiovascular complaint, and then some good questions to ask when you're taking care of a patient that has some sort of cardiac condition, and then we'll go over some anticoagulants. So they want you to be familiar with acute myocardial infarction or heart attack, CHF, aortic aneurysm, which I don't really know what you're going to be doing on the mountain for a few of these, but we can try to give some insight into what not to do for some of these. So times you want to give aspirin and nitro, and then when so basically you're not going to be giving any medications, but you're going to be potentially instructing people to take some of their own medications. So we'll go over those things. So we'll talk about all this stuff. All right. Blah, blah, blah. All right. Start with some basic anatomy here. We're going to skip through here until we get to a picture of a heart. There we go. Okay. Your cardiovascular system is made up of obviously the heart, and then all of your blood vessels, veins and arteries. Generally how this works is blood will start in the right atrium here. Can you see my cursor at all? Can you see my cursor? Okay. All right. So you got all of your deoxygenated blood returning from the body, kind of dumps into the right atrium here, and then down into the right ventricle. The right ventricle, when the heart squeezes, gets pumped out into the lungs. Now, blood vessels go from a increasing caliber to a decreasing caliber. So obviously you have your large vessels. The pulmonary artery is a very large vessel, but that gets smaller and smaller and smaller down into capillaries, which are what you would find in your fingertips and also in the lungs. And they're so small that blood cells can actually permeate through the membrane of the capillaries, and that's where your red blood cells pick up oxygen via your lungs. And when that blood is coming back, it is returning to the heart via the pulmonary vein, which the pulmonary vein is the only vein in your body that carries oxygenated blood. Every other vein in the body carries deoxygenated blood. So that's something a little different about that one. So on the way back from the lungs, the blood that is now oxygenated comes into the left atrium, and then when your heart is relaxing during diastole, the mitral valve opens, the left ventricle fills with blood, and then when the heart beats during systole, it is pumped out the aorta to all of your organs. So the pressures in the left side of the heart are much higher. That's why the wall of the left ventricle is much thicker and stronger. There's some conditions that can result in the right side of the heart muscle getting too big, and then we can have some significant issues from that. That's kind of the basic physiology of how the heart works. Something that a lot of people don't understand is your coronary arteries and how that plays into everything. So the important thing with that is if you have a blockage or low blood flow state through the coronary arteries, it actually starts to affect the heart muscle. So the heart muscle itself, which is basically the entire heart with a few exceptions, is a giant muscle, and it's made up of a specialized muscle cell called myocardium. And that myocardium is very good at conducting electricity, and it's very efficient at conducting electricity. That's how the heart is able to beat via electrical signals that are kind of spread throughout the cardiac myocytes. Now, the issue can be if, in the process of having a heart attack, your coronary arteries come off of your aorta. So when the heart is relaxing during diastole, these coronary arteries that come off kind of right about here, right after this aorta leaves the heart, that is what supplies the heart muscle with blood. So none of the blood on the inside of the heart is actually supplying the heart muscle with oxygenated blood. It's all from the coronary arteries, which take off from the aorta. And so that's kind of an important point to learn there, because we're going to be talking a lot about heart attacks and how to identify that. And that's where the blood flow to the actual heart muscle comes from, is some arteries that take off right from the aorta. All right, so let's see what it was supposed to talk about here. Okay. Whoa, we're getting into antibodies here. Time out. Okay. All right. All right. Sorry, one sec. Is this? Okay, I'm somehow in the wrong. All right, how did that happen? Okay, 1 second. There we go. Okay. Okay. All right. Like I was saying, arteries get progressively smaller into arterioles and then capillaries. And that's essentially all the cells, once the blood gets to them, the cells take whatever oxygen they need, and then that deoxygenated blood comes back via small to large vessels, eventually coming back through the inferior vena cava, which is carrying deoxygenated blood from the lower extremities, and then the superior vena cava, which is carrying deoxygenated blood from the brain and the upper extremities. All right. Okay. All right. We'll go over the valves here real quick, and kind of what's going on at any given time. So when you feel your heart beat, that is called systole, which your heart spends about 1/3 of the total time that it's beating in systole. So it's actually a much shorter period of time, but that is in order to give the heart time to fill up with blood. That period of time needs to be longer, and that's called diastole. So when you see systolic and diastolic blood pressure, that's what that means. When you're measuring systolic blood pressure, you're measuring the blood pressure when the heart is actually squeezing the blood out. And when you're measuring diastolic pressure, that's when the heart is relaxed and filling with blood. During that relaxation phase, the tricuspid valve and the mitral valve are open. So blood is coming into each of the ventricles from the atrium at that point in time. Then the electrical impulse is carried through down to the ventricles, telling the ventricles to contract. And at that moment, this causes the tricuspid and mitral valve to close, but the pulmonic valve and the aortic valve to both open. So that period of time, while it's a much more forceful contraction, only occurs that's only going on for about half or a third of the time that your heart is squeezing. So the conduction system of the heart consists of several different. Hold on, okay. Basically consists of several different areas. The first one is the sinoatrial node, and that's where the impulse starts. So that is kind of located up here somewhere in the right ventricle or the right atrium. That electrical impulse then travels, and this is kind of what gives you a little bit of atrial squeeze. There's not a whole lot of squeeze from the atrium, but there's a little bit just to kind of get that blood down into the ventricles, and we'll go over what that correlates to on an EKG a little bit later. So the sinoatrial node, then your impulse travels through the right atrium into your atrioventricular node or AV node. And that's kind of what connects the electrical impulse between the atria and the ventricle. Once it gets there, that signal then kind of comes down the septum here, and then via this thing called the bundle of His, you don't need to know that, and then it kind of spreads out into each ventricle. And this should be symmetric. So when that impulse from the atrioventricular node travels down this and out each of these ventricular walls, that contraction should occur at the same time. You run into issues when someone's had a heart attack, and let's say this section of the heart muscle is kind of not receiving as much electrical activity because there's been damage to those muscles. That can create a kind of asynchronous contraction, and that's something called a bundle branch block. We'll talk about that later as well. All right. I'm not going to tell you guys where the heart's located. Okay. Another thing to know about the heart is there's a sac that is around it called the pericardium. This will be somewhat important because this can create a couple of issues with the heart. There's a tiny bit of fluid normally between this fibrous sac and your heart muscle, which that's fine, but sometimes this can fill up with blood. This can get infected or inflamed, and then we can have some issues from that. All right. So we got some major arteries of the body. Obviously, carotid arteries going on in the neck. Femoral arteries go to the legs. And this is going to be pertinent to you guys because this will kind of determine where you're going to check pulses and kind of what kind of blood pressures correlate to being able to feel a pulse in certain areas. All right. There's your distal arteries that you can typically feel a pulse in are going to be your radial artery, which is located obviously just proximal to the base of your thumb in your wrist. That's a pretty easy one to find. Carotid arteries, that's a central, we call it central pulse, which is you can have a much lower blood pressure and you can still feel a carotid pulse versus if your blood pressure is on the low side, you may not be able to feel a radial pulse, but you can still feel carotid pulse. Femoral pulse is again considered a central pulse. And then the dorsalis pedis, posterior tibial, and popliteal, that's kind of behind the knee. And this one's right on top of the foot. This one is typically a little harder to find in the radial pulse, but it's fairly superficial on the top of the foot. So these are some areas that you can try to feel for pulses. But again, especially in a cold environment, there is a tendency to clamp down a little bit. So if somebody especially is cold and has some, low blood pressure from whatever, blood loss, heart failure, something like that, you may not necessarily be able to feel a good peripheral pulse. Okay, we just talked about that. This one down here is the posterior tibial. Good luck, like during an actual emergency, finding someone's brachial pulse. And then femoral and radial. Femoral is a little hard to find if they're wearing clothes. carotid is a pretty reliable source, especially if someone is unconscious. If they're not getting any blood flow to their brain, then that's a pretty good sign that you need to do something. All right, we kind of talked about veins. Yeah, so the inferior vena cava, another important thing to note is that that blood vessel runs kind of through the liver as well. So, and the inferior vena cava is one that typically can get affected a little bit more by trauma. We'll talk about this probably in the OBGYN chapter, but this can play into when you're resuscitating a pregnant woman, trying to get the baby off of the vena cava, because that can venous return back to the heart. All right. All right. So components of the blood, we have obviously plasma, platelets, white blood cells, red blood cells. You can donate any of these individually or whole blood. Typically what happens is when you give blood, they separate the blood out into its components, plasma, platelets, and red blood cells. Typically don't give a whole lot of white blood cells unless you're doing a whole blood transfusion. So obviously red blood cells carry oxygen to the tissues, supply all of your tissues, muscles, skin, everything with oxygen, which obviously it needs to survive. And then also kind of binds up carbon dioxide from those cells, which is the waste product, and takes it back to the lungs so you can breathe off that carbon dioxide. The white blood cells are, part of the immune response. A lot of things that white blood cells do, and then a lot of things that can cause you to have an increased white blood cell count, but mostly it's immune response versus stress or some other stressful event on the body can cause that white blood cell count to go up. Platelets are also very important. Obviously, they are what initiates your blood clot. So if you cut your arm, the first thing that's going to happen is those platelets form a plug to initially stop the bleeding. Then you start to form a more stable clot, which is where the clotting cascade comes in. And those are all other factors, clotting factors that normally circulate in your blood, and that's part of the plasma. One thing to know, aspirin is in ways a platelet inhibitor. So aspirin, the reason that if you're taking aspirin, you tend to bleed for a little bit longer is because the platelets do not work as efficiently as they're supposed to. Liver makes the platelets, so this can be another issue in patients that are cirrhotic and have poor liver function, is they're not producing the amount of platelets they should be, or they don't work properly. There are a number of issues with liver patients and bleeding disorders. So we'll talk about that as well. All right, so some of the cardiovascular emergencies you guys need to know about. Obviously, this is one of the most, if not the most common cause of death in the United States. And most of these things are the end result of chronic unmanaged conditions, such as high blood pressure, hyperlipidemia, smoking, a few other things. Eventually people will develop some of these issues. The number one cause of, and number one risk factor besides age and strong genetic predisposition is high blood pressure for a lot of these conditions. It can be the sole cause of congestive heart failure. It can almost be the sole cause of MI, in addition to having high cholesterol, plaque in your arteries, that type of stuff. And stroke is all kind of on the same spectrum. So a myocardial infarction or a heart attack is when your heart muscle is not getting enough blood, and a stroke is when your brain is not getting enough blood. And that can occur a number of different ways, including low blood pressure. You can have a heart attack from low blood pressure, just like you can have a stroke from that. You can have a heart attack from high blood pressure, and you can have a stroke from high blood pressure. Or there can be some kind of blockage or embolus, which is a little piece of blood clot that gets clogged in one of these arteries. So we'll talk a little more in detail about that as well. All right, so the first one is heart attack, known as myocardial infarction. Infarction just means tissue death. So, and this is a fairly common occurrence, especially in the United States. Your risk factors include high blood pressure, high cholesterol, smoking is a big one, age is a big one, strong family history of heart attacks, especially under the age of 50, can be a pretty high predictor and a concerning factor. When we're seeing patients in the emergency department and they come in with chest pain, we kind of use all of these data points to, in the absence of any other like firm confirmation, either with EKG or cardiac enzymes, we kind of use all of these other risk factors, including age, as a predictor for what kind of risk this patient is at for actually developing, if they don't have it at this point in time, developing a serious cardiac event within the next month or so. And that kind of changes what we need to do as far as stress testing or does a cath lab and have dye squirted into their coronary arteries to see if there's any blockages. I have seen this in people that are in their 20s. For the most part, if this is occurring in someone in their 20s, it's because they have some sort of disorder that makes their blood clot a lot easier. Whether that is deficiencies in some of the factors in your blood that prevent clotting. Most of these are genetic type things, especially if someone's having a heart attack in their 20s. And then obviously this is a huge cause of morbidity and mortality in America and the world in general, but those people with a lot of chronic comorbidities, this is a pretty significant issue. The worst thing that can possibly happen, and the most common thing that can happen from a bad MI, is that, like I was telling you, when some of that heart muscle dies and it doesn't conduct electricity so well, it kind of can send the heart into this weird rhythm that doesn't squeeze, and therefore you're not getting any blood to any of your organs. The most common one, or one we see frequently that can be from a MI, is called ventricular fibrillation, where the heart is essentially just quivering and it's not actually pumping any blood. There's still electrical activity going through the heart, but it's just not contracting how it's supposed to. So it's not getting any oxygenated blood out to the body. All right, coronary artery disease. This is you probably hear this term quite frequently. It is just considered narrowing of the coronary arteries for a number of reasons. The number one reason is atherosclerosis, which is buildup of essentially fat on the inside wall of the arteries. Typically, the cause, when you see somebody come in with acute myocardial infarction, especially one that we can see on an EKG, the most common reason is that one of these plaques that kind of sits on the wall of your arteries ruptures and then forms a totally occlusive clot within the coronary artery. And so when you go and put a stent in, you kind of go up there with a little wire, and then you put a stent where that plaque has just ruptured, just to open that artery back up. Now, sometimes if people have multivessel disease, so meaning several of their coronary arteries are almost completely occluded, they'll need to go for a bypass. Basically, that's where you take either another artery in the patient's body or a vein from their leg, and you kind of you circumvent that part that's plugged up. So you attach that vessel proximal to the occlusion, and then you attach it again distal to the occlusion. So you kind of just make a path for the blood to get around that clot in the coronary artery. Pretty fancy. Okay. All right. Next one is congestive heart failure. Typically, these are people that should not be at a ski resort for a number of reasons, especially at high altitude. Congestive heart failure is essentially, this can be due to a lot of different things, but the most common one is all of those chronic issues that I was talking about. Most commonly, long-standing uncontrolled high blood pressure and also having a heart attack in the past. This essentially means that your heart is not pumping efficiently. So if you were to look on an ultrasound of somebody's heart, it's supposed to be squeezing like this. Theirs might be doing this. So we measure that with something called ejection fraction, and that's essentially referring to how much of the blood is getting pumped out of your ventricle every time it beats. With congestive heart failure, a very low percentage compared to what is supposed to be happening is typically pumped out. Obviously, this can lead to a lot of issues, but one of the main issues is the blood starts to back up. It's like, you try to flush your toilet that's clogged and nothing happens, but your bowl just keeps filling up. And you can imagine that can create some issues, especially with the lungs, where you're trying to get blood from and also from the entire body. So there's multiple types of heart failure. You can have heart failure where your heart is still beating efficiently. You can have high output heart failure, and this can be from a lot of different reasons, including blood loss, thyroid problems, things like that. But the important thing to know and recognize are the kind of physical exam signs and symptoms of somebody with congestive heart failure. Most of the time, people know that they have congestive heart failure, at least people that see doctors, but it's entirely possible that someone may not know they have congestive heart failure. They come up to 9,000 feet and then they figure out real quick that they can't breathe at all, which has happened several times. So, you may be the person that's able to identify this, and we'll talk about some of those signs and symptoms. So you can have right-sided heart failure. A lot of times this is, again, a lot of different causes of this, but the signs and symptoms you're typically going to see, the most specific one or the most sensitive one, meaning if they don't have this particular finding when you're taking a history from them, you may want to consider some other things, and that's shortness of breath on exertion. So if you ask the person, hey, can you walk more than a block without getting extremely out of breath, or can you walk up more than a flight of stairs without having to stop and take some breaths? If they don't have that, that's the most sensitive sign or most sensitive history finding. So that's an important thing to ask. So shortness of breath on exertion. Another important thing to ask is if they're able to lay flat. So typically someone with congestive heart failure will feel like they're drowning if you try to lay them completely flat on their back. And this can be something, especially if you're transporting somebody in a toboggan, if they're laying flat and they can't breathe, but they have a history of heart failure, something to take into account when you're doing that. A lot of times you'll get lower extremity swelling like this, where you can grab their leg and make a thumbprint in their leg and eat cereal out of it. That will happen a fair amount of the time, a lot of these people, because the blood is not able to get pumped out by that right ventricle. And so it just keeps getting backed up in the venous system. And when that happens, a lot of the fluid or plasma portion of your blood kind of gets pushed out into the interstitial tissues, and it can't drain via the venous system because you've got backup going on in the heart. So it just manifests as a bunch of swelling in their legs typically. And that's called edema. The other thing that can happen is left-sided heart failure. The most common cause of right-sided heart failure is actually left-sided heart failure. So left-sided heart failure, by far the most common. The vast majority of the time people have both right and left-sided heart failure. But left-sided heart failure, essentially, as right-sided heart failure causes fluid to back up in your tissues, left-sided heart failure will cause fluid to back up into your lungs. This is the thing that causes shortness of breath on exertion, can't lay flat and breathe, that's a term called orthopnea. And then a lot of this weird thing that will happen to patients with CHF is they will randomly wake up in the middle of the night and be breathing extremely fast, can't catch their breath for a couple minutes. It's called paroxysmal nocturnal dyspnea. So if they are waking up at night and feel short of breath for a few minutes and then they're able to go back to sleep, that's something that is associated with congestive heart failure as well. So you basically just get a whole bunch of fluid on the lungs and you can't breathe. All right. You can have pulmonary edema for a number of reasons, and I don't know, this is probably addressed in another high altitude injuries chapter, but one of those reasons that you can get pulmonary edema is in itself high altitude. And that is typically a result of multiple things, including stress on the body, which increases pulmonary capillary leak, and more fluid kind of leaks out into the lung tissue. Another one is low partial pressure of oxygen. And those things can cause pulmonary edema in an otherwise healthy person at high altitude. Typically, these are mostly going to happen above 8,000 feet. It's pretty rare to get high altitude pulmonary edema under that. And even at that, it's fairly rare unless you do a very rapid ascent. And, you know, some people probably have a component of this, but the first thing you'll start to see is they're coughing, a little bit of low oxygen. I had a couple of guys get this. I spent a month and a half doing a research study on the top of Pikes Peak, which is about 14,100. And in terms of the world, it's not crazy high, but it's definitely high enough to give you high altitude pulmonary edema. So that's something to look out for as well. Just because they're otherwise healthy doesn't necessarily mean at high altitude they can't get pulmonary edema. All right. All right, so yeah, this is kind of what I was talking about with the high altitude pulmonary edema. When you have low oxygen in the bloodstream, and actually your body is much more sensitive to carbon dioxide, and when you start to have carbon dioxide build up in the bloodstream, it signals your brain through some chemical receptors that it needs to tell you to breathe faster. So you start breathing faster at high altitude, and then that kind of triggers off this whole cascade of events that ends up with you having fluid in the wrong places in your lungs. All right. So angina is a term essentially to refer to reversible ischemia of the heart. So it's kind of like if you were to put a tourniquet on your arm and your hand is hurting really bad for 30 minutes, you take the tourniquet off, you're going to have blood flow go back to your hand. Your hand's probably going to be totally fine. You're not going to suffer any permanent tissue damage. And it's the same deal with the heart. Except for, unfortunately, the heart does not have a period of 6 hours where most of your extremities do. So every minute that one of your coronary arteries is blocked off, you are losing some function of that heart muscle. So yeah, essentially it's the same thing with angina. A lot of times what will happen is you exert yourself. When you're exerting yourself, obviously your cardiac muscle needs more oxygen to do increased work, so pump faster. If you get on the treadmill and your heart rate's in the 130s, obviously it's beating faster, your heart muscle is using more oxygen. And so in doing so, if the arteries are narrowed a little bit and your body's unable to supply the heart muscle with the oxygen it needs, then it can start to get ischemic, and that can be painful. And that's what's referred to as angina. There's two types. There's stable and there's unstable. Stable angina is when, let's say I get up and walk to the mailbox, I have chest pain, I come back inside, I sit down for 5 minutes and it goes away. It never happens when I'm at rest. It's just my coronary arteries are unable to supply the amount of blood that my heart muscle needs to work. So you could be totally fine at rest, but your artery is narrowed, which may be able to provide your heart enough blood while you're at rest, but the fact that it's narrowed, it doesn't, you can't increase the amount of blood flow like you normally should. And unstable angina is when you can actually develop chest pain at rest. And unstable angina obviously is much worse and a sign that you may be closer to an impending heart attack. Okay, this is what I was talking about earlier. You have all the coronary arteries that run on the outside of your heart. You have like left main coronary artery, you have right coronary artery, you have your circumflex. There are a lot of different arteries that are not going to make any difference in how you treat this, at least from a OEC point of view here. So typically, unless anything is blocked off greater than 90%, this 90% is a different reason for saying 90%, but they will put a stent in if it's greater than 90% occluded typically. Here I was talking about the clot or the plaque rupture. That's a pretty common cause. And then again, this typically the anginal symptoms come when you have narrowing of the arteries, and then eventually that can turn into an acute myocardial infarction if one of those plaques tends to rupture. All right. I already talked about this. There's some other things that can cause ischemia to the heart muscle and low blood flow state through the coronary arteries. One of those things is low blood pressure. So if your blood pressure is not high enough to actually fill those coronary arteries, then that can create some issues. Another one that can create issues that most people don't think about is those coronary arteries are filling with blood during diastole when the heart's relaxing. If you have periods of time where your heart is either beating extremely fast or in an arrhythmia where it's not giving it enough time to relax and you're not giving those coronary arteries enough time to fill up with blood, that can actually result in a heart attack as well. Yeah, again, if an area of tissue ischemia kind of cuts off one of those electrical flow pathways, that can actually cause a deadly arrhythmia. And that's kind of the most immediately feared complication of a heart attack, is somebody going into a fatal arrhythmia. All right. Okay. So yeah, obviously different types of arrhythmias result in different signs and symptoms, different things you're going to see on the monitor. Obviously, it can make the heart really slow. It can make the heart really fast. It can make the heart beat inefficiently to the point where you're not getting any blood to any of your organs. And it can result in complete stop of the heart. Some of them are benign.
Taylor? Hello?
Medication
Lost sound.
Taylor?
I think his internet's going all wacky.
Well, we all have that. Let's see where he went.
I thought he was just sitting really still.
He probably was.
Did I freeze?
Really
Like a
still
mime.
really silent.
Let me
All right.
find him.
Let's see.
He's...
You got me back?
Hi, Taylor.
Yep. All right.
Are you good?
How long was I dead for?
Enough to wonder if you were breathing.
Oh, great. Okay. Did we get to AFib? We talking about that? All right. I'm going to start back on this one. Okay, so some people live with arrhythmias. Some people live with their heart being in an abnormal rhythm, which may not necessarily be dangerous in that particular instance, but it can certainly cause issues. A lot of people have atrial fibrillation. Most of the time, this is from the heart muscle getting stretched out a little bit, or from ischemia. So people with long-standing uncontrolled hypertension or previous heart attacks, a lot of those people end up developing atrial fibrillation. Another weird scenario where you can develop AFib is if you have a young person who has just been out binge drinking or doing a bunch of drugs, and they come in and they have an irregular heart rhythm. It's something that you're not going to be able to count out the beats. It's going to be very irregular. So if they're a young person, it could be something called holiday heart, which is atrial fibrillation, but it's from a different mechanism. The issue can be when this rhythm either gets too fast and you stop perfusing all of your organs, Or atrial fibrillation, this can be a big issue, is with clots. So when the atrium are not contracting normally, you have a tendency to form some blood clots in the atrium, which can then fire off into your brain, into your lungs, and then cause stroke. That's the most common complication of having atrial fibrillation. And that's why most of these people are on blood thinners. All right. There we go. So yeah, that's an important thing you want to ask about patients who have any sort of cardiac history. Are you taking blood thinners, especially if they have hit their head, if they're experiencing any sort of bleeding, but mostly if they hit their head, because that's gonna dictate kind of what you need to do. Even somebody that may have had what sounds like a benign head injury can certainly still have a intracranial bleed, and that's something to be especially careful for. Okay. Some other people that have to take blood thinners are people that get recurrent blood clots in their legs. Some people who have genetic inherited conditions that cause their blood to clot easier. But the main thing is that you need to know is it's going to be more difficult to stop bleeding in these patients. You may have to be a little more aggressive early on, and especially for the head injuries, it's gonna basically dictate what you do. As far as anybody on blood thinners pretty much needs to go to the hospital and needs to get a CT scan if they hit their head. So technically aspirin is a blood thinner. We see a lot of people on just a daily 81 milligram baby aspirin, and that's typically more of a preventative thing. Again, aspirin is a platelet inhibitor, so that'll not allow you to initially form that stabilizing platelet plug as easily. Then I don't know, so dabigatran, you're not going to see that very often. Most people are going to be on some of the newer oral anticoagulant agents, which are Xarelto. You've probably seen commercials for all of these. Xarelto, Eliquis are two of the more popular oral anticoagulants, and warfarin is still used pretty frequently. The annoying thing about it is you have to check your clotting ability, rather frequently. And warfarin has a lot of different medication interactions as well. But you pay like $3 for a full month of warfarin, and you pay about $500 for a month of Xarelto. So especially in patients that don't have insurance or don't have good insurance, then they're probably going to be more likely to be on Coumadin if they have to be in a blood thinner. Plavix is another platelet agent. Typically, you'll see patients on Plavix who have had stents placed or who have had coronary bypass. And cardiogenic shock is exactly the same mechanism of every other kind of shock, which is your end organs are not receiving enough oxygenated blood to prevent from sustaining damage. So your end organs are being damaged because they're not getting enough blood. And cardiogenic shock specifically is secondary to the heart not efficiently pumping blood out to those organs, whether that be from an arrhythmia or congestive heart failure or some other cause. Your heart is not pumping the blood to the tissues. Sudden cardiac arrest, it's a lot of time, most of the time it's caused by an arrhythmia. Ventricular fibrillation is a pretty common one. Like I was discussing earlier, ventricular fibrillation, the heart's kind of just quivering a little bit. It's not producing any useful contraction, and therefore no blood is actually really leaving the heart at all. VTAC is essentially the heart rate is going to be very high. You're going to have a very wide QRS complex on your monitor, and you can have VTAC and still have a totally normal blood pressure and be sitting there talking to somebody, or you can have VTAC and have no pulse, or you can have VTAC and have low blood pressure. So those are kind of going to determine, and on the mountain, the AEDs will kind of figure out what rhythm the patient's in and advise you whether to give a shock or not. But somebody in VTAC that does not have pulses, you defibrillate. Somebody in VTAC that has pulses but their blood pressure is low, you need to cardiovert those people. And then people that have VTAC and their blood pressure is stable, you don't necessarily have to do anything at that point in time, but usually we opt for medical. We attempt to give them some sort of medicine first. And then if that doesn't work, we can consider other things. But we typically don't like to shock people that are awake. I heard it doesn't feel good. Sometimes VTAC and a lot of times VTAC can actually lead to a cardiac arrest. So it's not something to be taken lightly, but that one is varied whether you will be producing useful beats of the heart or not. Unlike ventricular fibrillation, which typically you cannot perfuse any of your organs with that rhythm. Yeah. Without CPR or AED, pretty much everybody with sudden cardiac arrest is going to die. The most shockable rhythm, I guess, the rhythm that's always shockable is VFib. When you put an AED on, it kind of has some algorithms that will interpret the rhythm and then advise whether to give a shock or not. And then also, it'll kind of guide you through it. Check the pulse. If the patient doesn't have a pulse, it'll tell you to start CPR. And then if it's assuming the patient still doesn't have a pulse, if it detects either VFib or VTAC, then it will advise you to give a shock. All right. Pericarditis is not a cardiovascular emergency. Pericarditis is inflammation of the sac that is around your heart. There's a bunch of different things that can cause this. Most of the time, it's some sort of post-viral infection. It's not really an infection, it's more of an autoimmune thing. So much in the same way you can end up with heart disease and things after you get like a strep throat infection. If you have some sort of viral infection, your body produces antibodies to that virus, and there's some cross-reactivity with your pericardium that can result in pericarditis. Actually, if you have a myocardial infarction, about anywhere from 4 to 6 weeks later, you can get inflammation of the pericardium, which is called Dressler's syndrome. And really, this is not something, you may or may not be able to diagnose this without getting an EKG. But typically the patient's going to say that they're having chest pain first and foremost. The chest pain may get better when they lean forward. So you might see this person leaning kind of in a tripod type position. And yeah, usually worse with deep breaths or coughing, but that's very non-specific to pericarditis. You supposedly will hear a friction rub on exam, but I don't know that I have ever heard that, so good luck with that. Tamponade is when you have too much fluid between that fibrous sac and your heart. The primary problem is that that fluid is all compressing the heart, and it doesn't allow the heart to relax and fill with blood. And then you get something called cardiac tamponade, which you are unable to effectively pump blood to your body, and essentially results in end organ damage like all the other things that affect the heart. The only way to fix cardiac tamponade is to drain the fluid or blood, whatever it is, out of that pericardial sac. And that's something we do in the ER. You kind of put a giant needle up under their sternum into the pericardial sac and drain off blood or fluid. Pericardial tamponade happens mostly in trauma, and it's mostly blood related. I have seen one case, somebody had a malignant effusion. A lot of times people with certain types of cancer will develop pericarditis and accumulate a bunch of fluid between their heart and the pericardium as well. This will kill you. This will kill you pretty easily if you don't get something done about it. Usually you need to go to the operating room with cardiothoracic surgery, and they cut a little window out of the pericardium to help it continue to drain so that doesn't happen again. And then if it's a primary cardiac injury, that's something that obviously needs to be repaired as well.
Are you breathing? Taylor? Let me find you.
I think he has an unstable internet connection.
Probably. Let me see if I can find him. He's back. He's coming somewhere. Taylor. So what do you think of it so far? Above your head, or is it, you getting a lot of information?
I think it's a lot of information to grasp, but I think overall, just rereading the book and whatnot, I don't know. I personally shouldn't have a problem grasping it, once I can just reread it a couple times and really, get a firm understanding for it.
Right. And you have to remember, you're not going to be able to diagnose a lot of this. You're just going to know that the patient needs ALS transport to get them off the hill. Because once you see a patient like this, you're going to see they look like, excuse me, crap. They look like they're going to die. And you want to get them off the hill as soon as possible. So if you can see that, here we go.
I'm back. Sorry. The fastest internet speed in southern Mississippi is probably the slowest internet speed in Vegas.
Oh. Well, we missed you.
All right. Let's see if we can get back here.
We were in.
What'd you get to? Aneurysm? Patty.
Yes, that's where we're at, right here, where we can die right now.
Yep. Yeah, these people die. Even if if your aortic aneurysm ruptures and you're in the emergency department, you're probably still going to die. There is, short of having this patient in the operating room in 20 minutes with continuous blood pouring into them, this is something that is extremely fatal, even if everything goes perfectly. Again, this is something that everybody that's ever smoked gets screened for when they're 60, if you're getting all your routine screening stuff done, but often that does not happen. Your aorta forms a giant bubble in your abdomen and then it essentially explodes. So all the blood that's getting pumped to your legs starts to just pour out into your abdomen and you internally bleed to death. Very, very quickly. There is essentially nothing that you're going to be able to do about this to save anybody. Do the best you can. You get them to where they need to go, but in no way is this person have a high chance of living if their aorta ruptures, especially at Lee Canyon. They're at least an hour and a half from being on an operating table, unless they get flown out, in which case there's, again, some delays there, but the morbidity and mortality for this is extremely high.
Taylor?
Yes.
You see this in blunt trauma?
You see this in blunt trauma?
Yes.
So you can have aortic injuries. Typically, aortic aneurysms don't happen so often in trauma.
Okay.
I've certainly seen traumatic aortic injuries from bullets, stab wounds, just extremely, a lot of the worst injuries we get are from pedestrians getting hit by cars, which there's no shortage of in Vegas. So things like that can actually cause your aorta to tear. AAA rupture, I suppose that if you already had a AAA and you were involved in some sort of trauma, that could prompt it to rupture. But that in itself typically doesn't cause an aneurysm. Aneurysms form over years and years and years. And most of the time, these don't need to be repaired unless they reach a certain size. And that size is typically greater than 5 centimeters, which is fairly large because your normal aorta should be a diameter of 3 centimeters or less. And that's a quick thing we usually do with ultrasound in the ER is if we're suspicious for that, we can look at their aorta with an ultrasound, and it's fairly obvious to see when their aorta is, huge and ballooned out. Yeah, so aortic dissection is another bad one. This is a very notoriously difficult thing to diagnose because the symptoms are very widely varied, non-specific, and no one symptom is always present in every single one of these patients, and not even pain. Sometimes people will come in and say, my leg is hurting, or I have some numbness in my hand, and they'll eventually end up getting diagnosed with the aortic dissection. Essentially what happens is, this is typically due to long-standing, poorly managed high blood pressure. I don't know if you're catching a trend here, but pretty much every single one of these things, high blood pressure is a huge risk factor for. So essentially what this happens is you have multiple layers of all of your arteries, including the aorta, and some blood starts to kind of leak into the middle layers of that artery, and it splits the wall in half. So then you start to develop a false tract, and a lot of the blood starts pumping into that false tract. The problem with the blood pumping through the false tract is it's not getting into any of the smaller arteries. So the main lumen of the vessel where the blood is supposed to be going through, not enough blood is going through there, and that will then eventually result in some or all of your organs not receiving enough blood flow. A lot of times what will happen is if you get an aortic dissection that starts right at the aorta where it leaves the heart, that can actually cause a dissection in every artery in your body, because that false tract propagates up into all of your arteries. I saw a gentleman a few years back that came in and he had some like kind of twinge in his back and a little bit of like numbness, tingling in his fingertips. And this guy ended up having what's called a type A aortic dissection. And that's one that starts right at the base of your aorta, which is the worst kind. And those need to go to the operating room immediately. The surgery is pretty crazy. What they do is they cool your body down to, I don't know, low 80s temperature. And then they stop your heart. And from that point, they have about 20 minutes before your tissues start to die. So they stop your heart, they unplug your aorta from your heart, they put a graft in there to close down that false tract that you've created. And then they plug the aorta back in, restart your heart, and warm your body up. So it's kind of a race against the clock. It's a wild surgery. If you ever find yourself being able to be a part of one of those.
Quick question.
What's up?
Does the dissection, can it progress into an aneurysm, or are those they're just
No,
like
so those are different processes. So aneurysms are typically involve the entire thickness of the blood vessel, and those develop over years and years. A dissection is the layers of the wall kind of get split open, and you start to have blood flowing in a false tract. Typically with an aortic aneurysm, all of the layers of the vessel are outpouched. And then eventually they get stretched to a point where you can't handle it anymore, and that you develop a leak or a rupture. If it's a leak, you can typically fix it. If it's a rupture, then they're in trouble. Yeah, so thoracic aortic dissections, if it starts in the lower aorta or anywhere past the origin, it's called a type B. And a lot of times those can just be managed with medicines to lower the blood pressure, lower the heart rate a little bit, and they kind of get observed. The type A ones go straight to the operating room. Yeah, and here's this abrupt trauma to the abdomen or chest. The heart is kind of tacked down to the mediastinum by the ligamentum arteriosum, and it essentially keeps the aortic arch from moving around too much. When you get in a deceleration injury, this is something that often gets injured. You can actually create an aortic injury, dissection, aortic rupture, or hematoma with a quick deceleration injury, which is a prime example is somebody hits a tree skiing really fast. We see these a lot in bad car wrecks. if, you know, in the absence of all other injuries, a lot of times people can have aortic injuries from that deceleration. The heart keeps moving forward, the aorta is stuck in its place, and it can end up causing trauma because one of those items is fixed, the other kind of moves. All right. Oh man. All right. Okay, so primary assessment, obviously, scene safety. You're gonna do ABCs, see if the person responds to you. If they don't respond to you, then they're unresponsive. Get up there, feel for a pulse, see if they're breathing. These are kind of things you want to do all within the first 5 seconds. If they don't have a pulse, you're done right there. Start doing CPR. The next most important thing you need to do is get somebody to get an AED and get somebody else to call 911 to get ambulance transport, or if you already have an ambulance on the scene, go grab the guys who are responsible for transporting that patient. The AED is one of the best ways to save somebody with CPR. The combination of those two things can actually result in the patient having a decent chance of living. Right off the bat, if somebody arrests in the field, their chances of living are not great, but with early CPR, good quality CPR, and early defibrillation, these people actually have a chance of making it. The best place to go down is probably a casino because there's thousands of cameras everywhere. People are on you within 30 seconds typically, and all of them are trained in CPR. So, Sam's probably does a lot of calls at casinos. When I did ride-outs and stuff, I go to casinos pretty frequently. Somebody in cardiac arrest, we're typically getting CPR and AED on scene when we get there. And sometimes those people pull through, so.
Taylor, I'll jump in and intervene really quick. Just real world scenario.
Yeah.
So I do all the training at the Golden Nugget. I train all their officers in CPR, AED, first aid. And September 23rd, the CEO of UMC was standing in line to an event, witnessed somebody go down. The CEO of UMC provides immediate CPR. Security is there 60 seconds later with an AED, and it resulted in a code save. The guy was actually talking by the time EMS got there and wanted to refuse care, and they talked him into going to the hospital. He had a full bypass surgery a week later.
Yeah. Yeah, you'd be surprised how often that happens. It's wild. Like, that's funny though. Yeah. I had a guy at a racetrack that was, I was in med school. Just this guy got out of a go-kart and just collapsed. Same deal. Unfortunately, this place didn't have an AED, but the guy ended up being fine. So number one thing though, early CPR. And minimize interruptions in CPR. Those are the two things that are going to result in better survival than anything else. And then early defibrillation. So all those things are extremely important with a out-of-hospital cardiac arrest. Secondary assessment, obviously, if the patient is responding to you, if they're breathing, if they have a pulse, then you kind of move on to that secondary assessment. Then you can start talking to them, gathering a history. Obviously, you want to see if they have any other medical problems, if, this has ever happened before, if they have stents, if they're on blood thinners, ask any question that you can think of that may be related to, especially if they're having chest pain, lung problems, heart problems, history of blood clots, things like that. The number one thing that you definitely want to give in somebody that has chest pain like this, we'll talk differently. If it's a 17-year-old that fell and hit her chest on a mogul, then that's a different deal. But if this is a 60-year-old guy who's complaining of chest pain, the number one medication, and the only one that's really has a lot of good evidence behind it without any refuting studies, is aspirin. 4 baby aspirin, or 324 milligrams, 325 milligrams aspirin. Have them chew that up, and that in itself is the best medication that you can give somebody for chest pain, especially if it ends up being a STEMI or NSTEMI or something like that. If the patient took nitro, a lot of these people with stable angina will carry nitro with them, and so that could be something that they've already taken when you get there. If it improves their pain, great. Regardless, if they're having chest pain on the mountain, they take nitro, it goes away, they need to go down. Obviously, being in a low oxygen, low partial pressure of oxygen environment only makes all of these problems worse. Your heart muscle's not getting enough oxygen. Normally, you come up and just at baseline on the mountain, it's not getting enough. I remember last year we had this lady come up that had just had a pulmonary embolus like 2 weeks ago, was still on Lovenox, and then was getting short of breath on the mountain, and she was wondering why. So they, believe it or not, people with these problems do still try to come up to high altitude and are confused as to why their symptoms are getting worse. So yeah, again, loved ones or family members, friends can be a very important resource. If they can give you a medical history, if the patient can't, that's another important thing to do. That can, especially if you're transporting somebody and you can relay that information to the team that's transporting. A lot of times when I get a patient from EMS in the ER, their family members are far behind them. Either especially if they come in via helicopter, the helicopter is arriving 30 minutes to an hour, depending on how far they are, before the patient. So if you're able to gather information from the patient's family on scene and relay it to EMS, that can be extremely helpful on down the line, because that can affect what we do in the ER, especially if somebody has pre-existing conditions that we're aware of, if they history of pulmonary embolus before. And a lot of times, obviously, we can't get any of that history from the patient or their family if the family's not there yet. So that is something important to do. Heart medication, that means a lot of different things to a lot of people. Most people will not be able to tell you what the name of the medication is. They might take a stab at it and it sounds nothing like what the medication is supposed to be. But here's a list of some common ones. All of these are either hypertension medications or blood pressure medications. You want to pay specific attention to any sort of like antiarrhythmics or blood thinners. And then, if somebody's taking Lasix or a drug like that, you may want to ask. Obviously, they may not know why they're on it, but a lot of times it's from congestive heart failure or fluid overload status. All right, so this is your basic history. OPQRST is what you can memorize. Some people do the old CARTS one. It's all acronyms, but as long as you remember, O is for onset, P is for palliation, meaning like, does anything make this better? Does anything make this worse? Q is quality, so you just have them describe it. Does it feel tight? Like a lot of people with a myocardial infarction will describe, it feels like somebody's sitting on their chest. It's not necessarily like a stabbing pain, but more pressure than anything, or somebody feels like a band is being tightened around their chest. So yeah, those are part of your history. And if you tell them that if they want to rate it, so like 1 to 10, I don't know, that really doesn't mean a whole lot to me because everybody likes to say 11 and then we all just get pissed off. And then T is for timing. So like, how long does this last? When did it start? Has this ever happened before? That's a good question to always ask somebody. Has this ever happened before? And what happened when it did happen? That can give you a lot of time, a lot of information there. Usually, last time I had this, I had a heart attack and I had to get 3 stents. So that can kind of tip you off as to what might be going on. A lot of times the pain will radiate. You're not going to differentiate between a lot of this stuff, but for a fact that you need to get them to a hospital. In anybody that's having chest pain that you're suspicious for an MI, but they're still up talking to you, they have good vitals, give them aspirin. That's the one thing that they need to get on the mountain. The quicker that goes in, the better. And then they need to get down. And obviously oxygen can be helpful. If the patient is hypoxic, you need to give them oxygen. If they're not hypoxic, then you actually don't necessarily need to, but I believe it is in the OEC protocols. I should know. helped revise the Lee Canyon one at least last year. But if somebody's having chest pain, especially at high altitude, put them on a little oxygen as well. So this, I mean, you can get pain anywhere. The people that are going to get pain that may not be like your typical symptoms, you always hear like the old diabetic woman is somebody who's going to show up with a heart attack and her only complaint is going to be like, I felt a little tired for the last 2 days, and she'll, you know, have a heart attack. So in those type of people, it's going to be hard to tell, but just keep a high level of suspicion, especially in that type of demographic. You know, ripping, tearing pain is always the one we hear about for aortic dissection. That has not been my experience. It can range from that to I felt like, you know, a bee stung me on my back or something, you know, something pretty benign. Really the variance in presentation of aortic dissection makes it extremely hard to diagnose unless it's a classic presentation, which is, I find the classic presentation for aortic dissection is not the most common presentation, unfortunately. All right. Yeah, ask them if they use drugs. Meth, cocaine, some pathomimetics can actually precipitate cardiac ischemia, especially cocaine, because it's a vasoconstrictor. It makes your veins and arteries constrict a little bit. So if you already have a little bit of underlying disease, use a bunch of cocaine, especially if you use cocaine and alcohol at the same time, it creates a toxic metabolite that is a direct cardiac toxin. So those are some risk factors for heart attack as well, which a lot of people drink and use cocaine at the same time, especially in Las Vegas. So we could do your exam. Obviously, the things you need to look for: pulses, capillary refill, and then, you know, capillary refill may be tough, especially if their hands or feet are cold. It's going to be delayed. So that may or may not be the most reliable thing, especially on the mountain. But it can give you an idea that they're still at least perfusing their peripheral tissues. And then sweating is the one thing that you can't fake. So if someone is just sitting there and they're pouring sweat out of their face, that's a very concerning symptom for someone having a heart attack, because it's the only one of those things that you can't really fake. Yeah, so like radial pulse, you know that your systolic blood pressure is going to be at least 80. You need about 60 to perfuse your brain. You need about 65 to perfuse your kidneys. Your kidneys are the most sensitive to low blood pressure because they have the smallest little arteries in them. Obviously, your brain is relatively sensitive, but if you can feel someone's carotid pulse, you know that they at least have a systolic blood pressure of 60. If you can't feel a carotid pulse, they're likely going to be unconscious. So obviously, get their vital signs. Vital signs are vital. If they have high heart rate, low blood pressure, you know, other concerning things, that kind of determines how frequently you need to check their vital signs. If they're unstable, you need to do it more frequently. That way you can trend those vital signs, see if anything you're doing is making them better, or if they're getting worse quickly, then you can prepare yourself for doing that CPR or getting that AED hooked up. All right. Yeah, call for early transport. Anybody with these type of symptoms, you need to. That should probably be about the third thing you do beyond either starting CPR, whether they're awake, giving aspirin. You need to get them out of there as soon as possible. All right. High blood pressure. This is not something you're going to treat on the mountain at all. This is a lot of times something we don't even treat in the ER. So the problem can be with this: if your blood pressure is very, very high, sometimes you can get end organ damage from it. If they're seizing, if they can't see, if they have a headache, we no longer really classify headache as a sign of end organ damage from high blood pressure. And things like that, you may get concerned that, oh, is your blood pressure really high? If the person has their medicines with them and they haven't taken them that day, it's not a terrible idea to say, you should probably take your medication. When someone comes into the ER, they don't have any symptoms, and their blood pressure is high, we don't do anything. We just discharge them and say, take your blood pressure medication to home. The reason being is your chance of giving someone a stroke by reducing their blood pressure too quickly is higher than their chronic high blood pressure causing any issues. So if somebody's blood pressure is normally 170 over 100, they come to the ER and we drop that blood pressure real quick to 120 over 80. The pressure their brain has used to getting is no longer there, and that can actually result in somebody stroking out. So the American College of Emergency Physicians has a position statement basically telling all of us, like, do not treat asymptomatic hypertension in the ER, and definitely not in the pre-hospital setting typically. All right. So signs and symptoms, like I say, nausea, dizziness, anxiety can be another one that'll trick you, but in all scenarios, you should assume that if someone's having chest pain, it is not from anxiety. And then after you've ruled everything else out, which is not going to happen until this patient gets to the ER and gets a workup, then you can determine that this might be from anxiety. But if somebody's having a tight feeling in their chest, just assume that it's a cardiovascular emergency and not that the patient's having a panic attack or something. And a lot of people can tell you, if someone tells you they feel like they're about to die, then that's, you know, a pretty good indicator that something might not be going well for them. Again, heart attack without chest pain, it does happen a third of the time, unfortunately. Yeah, like I was saying, this patient right here is the one that's going to happen to you. This will burn you. Fatigue is very common, shortness of breath. Either way, in an old woman, especially one with multiple medical problems, that's an issue. This is what they call silent MI. You may not necessarily see signs of it at first, but they're going to have elevated cardiac enzymes when they eventually get their workup in the emergency department, even if we don't see a heart attack on the EKG initially. I feel like this is, yeah, so your signs of shock are going to be the same in all the rest of them. You're not perfusing your organs well, so that includes your skin. You know, you're going to have low blood pressure. You may have an altered mental status if your brain is not getting enough blood flow, sweating, anxiety, feelings of impending doom, all that type of stuff. All right. Yeah, so a lot of different causes of cardiogenic shock, whether that's an arrhythmia, myocardial infarction, your muscles not working, or this can be medication or toxic induced as well. So if somebody's overdosed on some of their cardiac medications, you can create cardiogenic shock from that as well. The things you want to do for CHF, obviously we talked about some of the symptoms of that earlier: swollen legs, short of breath when you lay flat, short of breath when you exert yourself. The lower extremity swelling is something that you can check pretty easily. There's a couple other ones involving the neck vein and some heart sounds that you're not going to need to worry about. But yeah, if they have a bunch of leg swelling and they're short of breath, say, okay, maybe this person has congestive heart failure. In which case, the only thing you're going to want to do there is not lay them flat. If they're having a really hard time breathing, give them oxygen. If their blood pressure is extremely high and they are having chest pain as well, and you know they have a history of heart failure, and they have nitro on them, it's not an awful idea if they take it. This is often how we treat severe heart failure exacerbations with pulmonary edema in the emergency department. And that is very conditional, though. The patient's blood pressure has to be high. If it's low and you give them, you know, they take their nitro, that can result in them dying. Tamponade, these people are going to be very short of breath. They're going to have, you're not going to see this probably, but they're going to have distended neck veins because that blood is not able to, the heart's not able to relax and fill with blood. So you're going to get blood backing up into your neck veins and the rest of your body. And their blood pressure is going to be really low. Typically, if you're seeing this on the mountain, it's going to be from trauma. Most of the time, people that have chronic effusions, ones that are developing over a long period of time, if they're developing over a long period of time, that pericardium has time to stretch out. And if it's from trauma, you fill that pericardium up with blood real quick. It doesn't have time to stretch out over time, and you're going to get tamponade much quicker than you are from a chronic pericardial effusion. Neural pulse pressure, again, that's another thing. When you take their blood pressure, if it's like 90/80, 90/70, something like that, then given all the other signs and symptoms, you can be suspicious for that as well. But again, that's not a very specific sign. You can have that in quite a few different conditions, and that's not something to hang your hat on. But that's just because the heart can't relax. So your pressure is staying a little bit higher in diastole than it should. All right. Aortic dissection, again, ripping, stabbing, pain, maybe. A lot of times it does radiate to the back because your aorta is right kind of in the middle of your chest, so you can have chest pain, back pain. You may have some weird neurologic symptoms in your extremities, like I can't feel my hands, my arms are tingly, something like that. And again, aortic rupture, that's something that's going to happen with like blunt chest trauma, rapid deceleration injuries like hitting a tree. AAA, you're going to have pretty bad abdominal pain. One thing that a AAA has never been ruptured by somebody palpating their abdomen. There are no reports of that ever happening. If you think someone has a AAA and it's already ruptured, you touching their belly is not going to make this worse. That is a promise. But you touching their belly could tell you whether it is ruptured or not. The one thing they're going to have, so blood is very irritating. Anytime blood gets into a spot where it's not supposed to be, it's extremely irritating. So if you get blood in a place in your belly where it's not supposed to be, that will create what we call a rigid abdomen. So their belly is going to be rock hard. And you ask them, hey, can you relax your belly? They can't do it. That is fairly specific for what we call an acute surgical abdomen, meaning some sort of problem in the belly that needs to go to the operating room, because that lining of your abdomen is extremely inflamed, whether that's from blood, infection, something like that. But somebody you suspect that's having severe abdominal pain, older guy, maybe has smoked, his blood pressure is not so great at that very moment, or you can't feel any pulses in his femoral pulse or his feet, and you push on his belly and it's rock hard, that makes you extremely suspicious for ruptured aneurysm. These patients are in trouble. They look terrible, and there's not much you're going to be able to do about it, except for get them to a hospital. PE, shorter breath, tachycardic. A lot of times somebody will have, this is one you got to take a good history for. Their pulse ox may be low, but the most common sign that people will have is both tachycardia and tachypnea, so they'll be breathing a little faster. If somebody has a PE at 8,000 feet, they're most definitely going to have some sort of respiratory symptoms. You take their blood pressure and it's low, that means that if this is in fact a pulmonary embolus, they probably have a pretty big one. And that kind of changes things on my end, but not so much for you. Regardless, they need to go to the hospital immediately. Okay, 1 second, my battery's running out here. Hey Sam, can you bring me my? So a lot of times I'll have this like pleuritic chest pain, which can be described as sharp. That's not often a feature of someone with a PE. A lot of times they do get hypoxic though. So put them on some supplemental oxygen, get them to the hospital. If somebody has like a big cast on their leg, or they just recently had surgery, or they've recently been immobilized, those are significant risk factors for pulmonary embolus as well, including like a family history of blood clots. So those are things to ask in the history that can kind of make you more suspicious for that. DVT, most pulmonary emboluses come from big blood clot in the leg. You look at their leg, one of them might be swollen, one of them might be red. If you squeeze their calf, it might hurt. Again, all of these symptoms can be present or none of these symptoms can be present. None of them are extremely specific or sensitive to PE, but you know, the combination of history and some of these physical exam findings can make you suspicious for it. If you get DVTs in your bigger pelvic veins, those can cause very large pulmonary embolus, which can make you hemodynamically unstable. It's called a saddle embolus or a segmental pulmonary embolus. And a lot of times those will occur in patients with some underlying risk factors or some kind of anatomical variants that create these very large DVTs. You should be able to see some of these signs or symptoms in the patient's leg if they have a very large DVT. All right. So all of these, time is muscle, time is brain, all this stuff. Anytime you cut off blood flow to the heart, especially the heart and muscle, it starts dying. So you're on the clock. What we say is from the time the patient hits the door to the time they need to be in the cath lab getting stents if they have a heart attack is 90 minutes. And that is including if somebody shows up at a hospital and they need to be transferred to somewhere that can put a stent in. We either need to give that patient something like a really powerful blood thinner, or they need to be in the cath lab in 90 minutes. That's a fairly well-studied thing, and the survival rate and morbidity starts to go down significantly after that 90-minute period. So these are the things you want to get somebody to definitive care as quickly as possible. Again, not a bad idea to have these people on at least a monitor, have that AED pretty close by, because if somebody is having an MI, then there's a fair chance they may end up going into an arrhythmia at some point. So you want to be ready for that. Obviously, all your ABCs, airway open. You want to give this person high flow oxygen especially if they're breathing, they're looking terrible. Never a bad idea. You want to. This is true except for in somebody who may be having a COPD exacerbation, but for the most part, patients, you want to try to keep their oxygen saturation above 94%, which is going to be a little more difficult at higher altitude. So a lot of people will be in the low 90s just at baseline at that altitude. So don't be overly surprised if you see somebody with a saturation of 92% at 8,000 or 9,000 feet. They may not necessarily have any underlying lung problems at that point. All right. Cardiac arrest, obviously went over all this. Early CPR, early AED, early transport, all these things are going to help with survival. And then you need to recognize whether this patient has a pulse within 5 seconds, 5-10 seconds. If you can't determine whether they have a pulse or not, but they're completely unresponsive, you would think that finding a pulse is an easy thing, but turns out not everybody's great at it, because a lot of times we'll be using an ultrasound to look at someone's heart or look at their peripheral blood vessels during a code, and we can see good blood flow with the ultrasound, but someone can't feel a pulse. So if you can't feel a pulse, though, start CPR. All right. Yeah, so again, ABC, if they don't have circulation, if you don't feel pulses, you're kind of done there. You start doing chest compressions, open the airway. You're checking for breathing. Unlikely that the person is, they certainly could be breathing if they don't have a pulse, but it's more likely for somebody to have a pulse and not be breathing than the other way around. All right. Yeah, there you go. This pretty much sums it up all at the bottom here. So just do it all at the same time. It's obviously helpful to have more than one person, and that's why we have radios and multiple people responding to different things. So everybody can kind of help out in doing each of these things. All right. You guys all have to take BLS class, so this will all be covered in that. Again, yeah, survival rates drop significantly when you delay CPR. And it's not just doing CPR, it's doing it well. Most of the time you're going to end up feeling somebody's ribs crack underneath your hands. That doesn't mean you're going too hard. It probably means you're doing it appropriately. But the most important thing, and I see a lot of people that have never done CPR, they try to go too fast. You get a lot of adrenaline going. You need to give that heart time to relax and fill with blood. If you're doing this and you're never giving it enough time to fill with blood, then you're not doing high quality CPR. You have to give that heart time to fill with blood after each compression, or you're not pushing any of that blood out to the body. All right. Yeah, don't stop unless you get a pulse on one of your pulse checks, and then obviously you got to continue to monitor the patient. Scenario that you may have at some point, and this is the worst scenario ever, is when somebody has like severe heart failure to the point where their heart is not pumping enough blood to really sustain life at all. You start doing CPR, they wake up, they yell at you, you stop doing CPR, they die again because their brain's not getting any blood anymore. Start doing CPR, they wake up again, yell at you, but you're kind of between a rock and a hard place at that point, because the person's native heart rate is not able to sustain enough blood pressure to keep them conscious. So hopefully you never encounter that scenario, but it's possible. All right. Yeah, VFib, VTAC, pulseless VFib and VTAC, you're gonna defibrillate with an AED as quickly as possible. It'll tell you to shock that. If somebody has a pulse in VFib, it's not going to tell you to shock them, but it's assuming that you are analyzing this person because they don't have a pulse. All right. Yeah, better survival rate with AEDs, obviously. You got to do it quick, though. So that's why we have multiple of them all over the mountain. And everybody's got different roles. One person doing CPR. If you have two people on the scene, one person doing CPR, the other person putting pads on, messing with the AED. You can get anybody to call 911. It doesn't have to. If you got two people, the most important things for you to do yourself are CPR and AED. Obviously, you have other people in the area that are trained to do CPR, which is often the case. Last year, we had some off-duty firefighters that were up there and were able to do CPR, which is great. Utilize the people that are around you, but you can definitely farm out having someone call 911. All right. And then, obviously getting EMS there as soon as possible to get the patient to definitive management, whether that is unfortunately pronouncing the patient, or if they get ROSC, getting whatever intervention they need to reverse the cause of why they went into cardiac arrest in the first place. And then post-care, these are going to be things like cooling the patient, other things that you're not going to need to necessarily worry about. Two things you can do for somebody went into arrhythmia and coded because of a heart attack. This is not something that happens very often, except for if you're in a rather rural setting. Usually you can get patients to a place that they can do PCI, or percutaneous coronary intervention, within 90 minutes. And that's essentially just putting a stent in, or whatever they need to do in the operating room. Thrombolytics, you're only going to give those if you don't think you can get the patient to the cath lab in an hour and a half. So stents, we talked about this a little earlier. CABG, coronary artery bypass graft. If someone says CABG, they mean they had a bypass. God, I really hope that you never encounter anybody with an LVAD on the ski resort because they absolutely should not be there probably. This is essentially someone whose heart doesn't work anymore at all. And they put a machine in there that there's a pump in it, and it pumps the blood for your heart. So your heart's may or may not be doing anything. It could be beating, it could be in ventricular fibrillation. It doesn't really matter because there's a machine pumping the blood through your body. There's tubes that come, there's wires that come out through your chest wall, and then there's a battery. So you're essentially like walking around with this nuclear football that's keeping you alive. It's got batteries in it. There's no LVAD centers in Las Vegas. The nearest LVAD center is UCLA. That's where we had to send everybody that came in with LVAD problems. The issue is these patients are not going to have a pulse typically because it's just continuous blood flow. There's no pumping. So you're not going to necessarily feel a pulse in these patients. It's just going to be a continuous like machine type sensation if you try, or a machine type sound if you put a stethoscope on their chest. If these people go unconscious, just don't worry too much about it. I mean, you could do CPR, but you're going to completely destroy their heart muscle because this machine is like implanted into their heart. So there was at one point they said, oh, don't do chest compressions on somebody with an LVAD. But if you come to the point where you're having to do CPR on someone with an LVAD, there's like a 99% chance they're going to die anyways. Hopefully you never see anybody with an LVAD. But yeah, because like I said, their heart can be in any rhythm. It doesn't matter because their heart is not actually providing the blood flow. It's the pump. So the pump's working and their heart's in VFib doing this or whatever. It doesn't matter as long as they still have blood flow. AICD is a defibrillator or pacemaker. A lot of times people have both. Hopefully, sometimes this will shock the patient when they go into a lethal arrhythmia and restore a normal beat. Something you can do that if this will be more for EMS situation, but if you put a magnet over the AICD, it does not turn it off. A lot of people think that if you put a magnet on one of these defibrillators or pacemakers that it turns it off. That's not true. It just sets the pacer to a fixed rate. There's a lot of ways that these pacemakers work, but if you put a magnet on it, it just sets it to a fixed rate. It's not going to worry about sensing. It's not going to worry about monitoring for your heart's own beat. It's just going to pace at a specific rate. So it does not turn it off if you put a magnet on it, unless they're getting shocked inappropriately. In which case, if you're doing CPR on one of these patients and you have an AED on them, you don't want the patient's defibrillator also shocking them if you have pads on them and you're shocking them. So that's another scenario where you want to put a magnet on that. Anyways, you can do everything with these people. If they have a defibrillator, implanted defibrillator, pacemaker, CPR, defibrillation, do all that stuff. Don't worry about messing up the pacemaker. It already is not doing what it's supposed to. All right. Again, just anybody with chest pain, they need to go to see somebody in the ER. All right. And then CHF, seated upright is important. That can help with their breathing. And don't elevate their legs either, because that is going to create some issues as well. Oxygen, keep their oxygen normal. You don't need to you can give high flow, but if you have somebody at 98% oxygen, you don't necessarily need to have them on 15 liters non-rebreather, especially if it's like mask is giving them anxiety or whatever, and their O2 sats are 99%. If you put them on a nasal cannula at 4 liters or whatever, and their sats are 98%, there's no reason that you need to put them on high flow at 15 liters per minute. So the issue being that when we've studied this, patients that are not hypoxic, meaning their O2 sats are not less than 94%, if you give them too much oxygen, in excess, it can actually create free radicals and can cause more damage than good. So if the patient is not hypoxic, you don't need to flood them with oxygen, especially if their SATs are in the high 90s. Yeah, here's this, what I just said. All right. Yeah, so if somebody has their own nitro and they take it and it helps, great. But probably there are a couple situations where if you give somebody nitro, it can actually make them a lot worse, make their blood pressure get lower. Make sure they're awake, obviously. If they have chest pain, if they have nitro on them and they normally take this medication, okay, fine. But if they have low blood pressure, if they've taken like Viagra or any of these other medications and they take it, it can cause them to be hypotensive. And you know, there are certain areas of an EKG where if you see a myocardial infarction, you don't want to give these patients nitro, but you're not going to be making that determination on the mountain necessarily. All right. This is kind of how to administer that. You're going to put one of these tablets, you can put the tablet underneath the tongue, allow it to dissolve. And sometimes, you know, if they're still having chest pain, you can do this every 5 minutes for a total of 3. You want to make sure you take their blood pressure after every time because, again, this medication can make you hypotensive, especially if they have a certain type of like inferior MI or right-sided MI. This can cause them to actually become hypotensive. All right, aspirin. This is one that you always want to give if somebody is having, like the consequences of giving someone aspirin that they don't need are extremely low. The consequences of not giving somebody aspirin that they need are quite a bit higher. So this is a very beneficial medication, especially when it comes to risk benefit. I mean, unless somebody has a history of anaphylaxis to aspirin, that's about the only reason not to give it. Or yeah, again, if they can't swallow it, you're not going to like throw it in their mouth. Okay, just give them 4 tabs. You can either give them a 325 milligram tab or 4 baby aspirin. Have them chew it up and then swallow it. Give them water. I mean, just pretty basic there. Don't have the patient like walk anywhere or up a bunch of stairs if you can manage, because any type of exertion is going to make this worse. These people are probably going to die. These people are not going to do well. These people should be okay. These people also may not do very well if they develop these conditions on the mountain and they are, you know, 30 minutes from getting medical care. So obviously do what you can, but you're not going to be able to really do much that's going to change the outcome, except for one thing, which is get them where they need to go as fast as possible. All right. All right, so take a look at this. All right, 65-year-old guy, chest pain. He's sitting on a log. He is in distress. He's hiking, and he's got some crushing pain in his chest, down his left arm. He's got a history of heart problems, but he's never really had pain like this before. He's weak and nauseated, and he's sweating a lot. Remember, that's one of the things that you can't fake sweating. So anybody want to tell me what your first step here should be?
ALS.
Yeah, so I mean, start with your ABCs. Obviously, you're able to talk to the patient, so his airway is patent. He's phonating. You can go up, take his pulse. Got good peripheral pulse. The next thing you should do, though, he's out hiking. You need to get this guy to a better spot, and then, you know, once you complete your primary survey, you can get a little bit of a history, but you obviously want to make sure this guy does not exert himself any more than necessary. If he is a guy who has a history of heart problems, and he, you know, like I said, you want to make sure you get that good set of vitals before you give him any nitro if he's got it on him. But primarily you want to transport this guy to the first aid hut or whatever first, get a good set of vitals after you've already completed your primary survey, and then finish your history there. So first step though, but you should also be calling for some backup, potentially calling for an AED or going to a place that has one, and then calling for transport at that point. I mean, you got an old guy complaining of severe chest pain. He's going anyway, so the earlier you get that going, the better. All right, cool. I think that's it for this one. I'll give you guys a 5-minute break or something. All right. So we're going to do all of GI, GU, and reproductive organs. Yeah. A lot of anatomy, a lot of things can go wrong. Not a lot to do about many of them on the mountain, but we can try. All right, so we're gonna do all this stuff. We're gonna go over all these. All right. You eat things, it goes through your esophagus into your stomach, and then it goes to your small intestine, and then to your large intestine, and then out through your anus. That's the GI tract. Just one long tube. All right. But the goal is what they want you to be able to do is kind of maybe identify some of these conditions. There's a lot of vague symptoms that are nonspecific associated with a lot of dangerous things that can be going on in the belly. Yeah. All right. And then what to do with pregnant people. That always scares. That scares a lot of people when they see somebody that's pregnant. But there are a lot of pregnant people out there, so got to know what to do with them. Okay.
Send them home.
Yeah. Go get them away from here. All right. So you have the upper and lower GI tract. The thing that separates the upper GI tract from the lower GI tract is something called the ligament of Treitz, which is a fibrous structure that it tethers the first part of your small intestine to the back part of your abdomen. You have 4 quadrants in your belly. You have your right upper quadrant, which is where your liver and your gallbladder hang out. Left upper quadrant, which is stomach, spleen. And then right lower quadrant, the thing that you want to know that down here is the appendix. And then your left lower quadrant, which is your sigmoid colon, and then your rectum. Women have a lot more things that can be going on down here because there's a uterus and 2 ovaries in there, and men don't have that stuff. Hollow organs are, things like stomach, gallbladder, things that have air or fluids inside of them. The liver is a solid organ because it's pretty much the same consistency all the way through it. A lot of these organs have digestive functions in addition to synthetic functions. So for instance, the liver is responsible for kind of detoxifying the blood. It converts a lot of certain things that you digest into other metabolites like Tylenol, and it will produce protein, it produces clotting factors, it produces platelets. And those are the things that get messed up when you have liver failure. So you can't detox your blood, you can't process certain medications, you can't make protein as efficiently, you can't form blood clots as efficiently. The pancreas secretes a couple different things, and pretty much the gist of it is it helps you digest fat. So it's the same with the gallbladder. It helps you digest. So when you eat a fatty meal, your gallbladder squeezes and secretes bile. the bile comes out through something called the common bile duct, and that gets out into your small intestine. The pancreas also makes insulin, which obviously we all need to survive. So people with type 1 diabetes, the cells in the pancreas that produce insulin, theirs do not work. Whereas type 2 diabetes, the cells in your pancreas still work and you still make insulin. It's just all of the cells in your body are resistant to that insulin. So type 1, they don't make insulin. Everybody has normal flora in their gut, which is good bacteria. It helps you digest food. You can have some issues if you kill too much of that good bacteria with antibiotics. Some of the bad bacteria can start to grow over a little too much, and then you can get some infections, bad diarrhea, C. diff, if anybody's heard of that. A lot of times that is from antibiotic use or from being in the hospital. You contract that. Problems. The biggest problems come when any of these intestines, gallbladder, or stomach perforate. That can spill abdominal contents into the places where it's not supposed to be. So bacteria, fecal matter, bile, things that you don't want to be floating freely around in your belly. Those are when you get into trouble, and that's where you get a ruptured appendicitis. It kind of spills bacteria out into your belly, and you can get really, really sick from that.
Hey, Taylor.
Yes.
I think that the screen doesn't look like it's sharing. Or if it's sharing, but it's not like actually like doing a slideshow.
There we go.
All right, thank you.
All right. I've just been talking at you. Anyways. Okay. Everybody can see this?
Yep.
All right, good deal. Okay. So there's two kind of front division and the back division of your belly. You have the peritoneal space and you have the retroperitoneal space. The things that are behind the retroperitoneum are your kidneys, your abdominal vessels, and then certain parts of your intestines. One part of the small intestine and a section of the large intestine as well. So you have your kidneys back here. These are pretty important. They kind of filter out all the stuff that you don't need in your bloodstream and help you excrete all of that. Again, you have your large vessels, you have the aorta, you have your renal arteries, and then this kind of, you have a large mesenteric artery, which supplies your small intestine with blood flow, and then a bunch of other smaller branch arteries that make up the mesentery and other vessels that supply your stomach and a couple other places. We talked about this just very recently, so we'll kind of gloss over that. All right, abdominal pain is a very hard thing to pin down sometimes because like you have a pain on your arm, you can tell me pretty specifically where that pain is. The pain fibers and receptors on your intestines, they don't work like that. It's called visceral pain. And these nerves, when they get irritated or you have squeezing in your intestines, it's really hard to localize exactly where that pain is. And that's something called visceral pain. And a lot of times you can get things in the belly that pain travels. So let's say you have a cholecystitis or your gallbladder is infected. Your gallbladder is right next to the diaphragm. That can irritate the diaphragm. And then you can kind of get some referred pain up to your right shoulder or your right scapula, something like that. So that's what's referred to as referred pain, where pain in one area causes irritation and then you feel pain in a different area. All right, so female reproductive organs, a lot of things can go wrong here, and it's harder to diagnose than male problems because the female organs are on the inside. kind of in with all the other stuff that causes problems. So this, obviously, you got ovaries, you have fallopian tubes, you have the uterus, and then the cervix. Those are both in the pelvis, something that is, relatively analogous. Male, obviously, testicles, where you have your vas deferens, and then all this bladder that connects with the urethra down and out through the penis. And then you got your prostate hanging out somewhere in there. All right. Gastroenteritis, this is probably the most common GI problem. This is, most of the time, like 90% of the time, caused by a virus. This will result in vomiting, diarrhea, maybe have symptoms for a day or two, and then you get better on your own. Your body fights it off. The biggest issue from these are getting dehydrated, which can happen pretty quickly if someone's having vomiting and diarrhea and you're unable to drink any water. You typically have some cramping type pain. The risk factors for bacterial infection are as if you've been maybe drinking out of a weird stream or something lately, or you've traveled to a foreign country. You can get traveler's diarrhea, cholera, giardia, things like that. But if somebody has more than 10 episodes of diarrhea per day for longer than about a week, then we start to get more suspicious that this may be like a bacterial thing that needs a little bit further workup, or potentially antibiotics. If you have a lot of risk factors for bacterial infections, then typically antibiotics are considered earlier. But if for somebody who is complaining that they've thrown up 5 times and had a couple episodes of diarrhea in the last 6 hours, it's probably going to go away on its own 95% of the time. These people it's not really necessary to give them antidiarrheals unless you get to the point where you're having more than 10 episodes a day. There can be some unwanted complications from giving antidiarrheals that, unless it's like severely interfering with their ability to do anything without being 5 feet within a bathroom, or within 5 feet of a bathroom, I typically don't give antidiarrheals. Blood in the stool or vomit, there's a bunch of different things that can cause this. If it's a lot of blood in the vomit, then we got problems. If it's a little bit of blood in the vomit, probably not a big deal. And same deal, if you got bright red blood in your stool and it's a little bit, probably not a big deal. If you got a lot of blood, or you have black, tarry, sticky type stool, that's a big problem as well. Either way, they need to go get seen at a medical facility and stop being on the mountain, probably, if they're vomiting blood. All right. These are hard to differentiate. Like even for somebody who's been doing this for a while and has a bunch of training, you can't typically look at somebody and get a brief history from them and tell them exactly what's going on. Common things being common, if they have had some sort of like food ingestion, especially if they eat food that's been sitting out in the sun, things with mayonnaise in it, it's more likely that they ingested some sort of preformed toxin, especially if they're having like vomiting within 4 hours of eating something that is more consistent with like a foodborne type thing. Diarrhea usually takes between 4 and 6 hours for something to get through your GI tract, at the quickest. So at that point, you may start developing some diarrhea. The non-preformed toxins, bacterial stuff, it's going to take a little while to formulate in your gut, so you may not actually have any symptoms until the day afterwards. And this is a thing you can just ask, like, hey, does anybody else that you ate with have similar symptoms? What did you eat? Just taking a good history. Travel always needs to be part of your history taking, asking if they've been anywhere recently that, or, if they've eaten or had anything to drink that's not like standard, or if they've eaten anything that's been kind of sitting out. E. coli is fairly common. The norovirus, especially in babies, this will show up with like bright green poop, and they usually have fevers. That norovirus is very, very common, especially in the winter. Norwalk virus is also known as the cruise ship virus. That's the one that just spreads like wildfire on cruise ships. So they can shut down your entire cruise, which is miserable. Or the sewage system gets full on the cruise ship. It's not a good situation. And then Giardia and crypto. Typically, you're not getting crypto diarrhea unless you have full-blown AIDS. So that's crypto's not that common, but those are both protozoa. Giardia is a little bit more common in immunocompetent people, but again, both present in water. All right, so appendicitis. This is another very common abdominal issue, mostly a disease of the younger person, although not impossible to get it if you're older. The most specific, or the most sensitive sign, meaning if they do not have any right lower quadrant pain, this is likely to not be an appendicitis. Again, there are cases where it's not the case, but by and large, if someone has no right lower quadrant pain, they probably don't have an appendicitis. And again, if you push on their belly in the right lower quadrant and they don't have any pain, unlikely to be an appendicitis, although not impossible. You'll learn that anytime somebody says definitely or never in medicine, they probably don't know what they're talking about, because I am, especially working in the emergency department, nothing is impossible. Once you see enough weird presentations of stuff, you will never say, oh, somebody with this is always going to have this symptom. It's just not the case. Most people will, but there is almost no 100% certainty in anything in medicine. So just take everything kind of with a grain of salt, but it means you need more than just one thing to make a diagnosis. So this little useless structure here, your cecum, is sometimes it'll get plugged up, and then whatever's in here gets infected and it blows up like a balloon, and then it'll rupture. If it is ruptured, they're probably going to have pain all over their belly because they've just spread infectious matter all over the inside of their peritoneal space, which results in severe abdominal pain. And like I was talking about earlier, you get that abdominal rigidity when you have irritation of the lining of your abdomen. The same thing with blood. Blood irritates it, and then it just kind of all makes all of your abdomen very rigid. So if you feel that, someone has something serious going on in their belly. Yeah, typically the classic presentation, you have periumbilical pain. So you have pain that kind of starts in the center and then migrates down to the right lower quadrant. You have anorexia, vomiting, maybe some fevers. It's something somebody needs to go to the hospital for. Pancreatitis, there's some risk factors for pancreatitis. Usually the most common cause in the United States is alcohol-induced pancreatitis, followed by basically where you get a gallstone into the common bile duct, and it also plugs up the pancreas. So the pancreas is trying to drain into your intestinal tract, but a gallstone has made its way down into the common bile duct and blocked off the ability for the pancreas to put its enzymes out into the small intestine. So what happens is the pancreas gets really angry. It secretes a whole bunch of this enzyme called lipase, and it makes you very sick. You start vomiting, you have a lot of pain. Typically, what people will describe a pain that starts kind of in their epigastric area, right underneath their sternum, and it bores through to their back. They'll have vomiting, plus or minus fevers. Again, this is a good history to get if they have a known history of gallstones. You can get it from some certain medications, infections, and then the other one that can also give you this is if you have extremely high triglyceride level, you can get a hypertriglyceridemia pancreatitis. Although that is relatively rare, it's not impossible. Again, you're not going to diagnose that on a ski resort. So kind of already talked about this. Pancreatitis, it is an emergency. It's a surgical emergency. It becomes even more of an emergency if they have a ruptured appendix. And a lot of times what will happen is the people with a ruptured appendix don't necessarily go to surgery immediately. They will eventually, but we'll end up sometimes giving them antibiotics and trying to get that infection to calm down a little bit before getting into the belly. Because if you go in there, ruptured appendix pretty early on, it tends to be kind of a mess. And so you like to get the patient a little more stable before doing surgery. If it's non-ruptured, it's pretty easy. You go to the operating room. Typically, it's done laparoscopically, so minimally invasive. They just take your appendix out. All right. Chronic pancreatitis is a whole ordeal that makes your life miserable. People get chronic pain in their epigastric area, typically after drinking alcohol, things like that. And this can eventually lead to pancreatic failure. Your pancreas just kind of burns out. You may develop diabetes. You can develop necrotizing pancreatitis, where your pancreas basically just melts inside your body. It's a disaster. Try to avoid pancreatitis at all costs. Hepatitis is any sort of inflammation of the liver. This can be due to infection. This can be due to autoimmune conditions. This can be from Tylenol overdose, chemicals, things like that. People turn yellow. So if you look at their eyes, they can have scleroicterus, which is yellowing of the eyes, or jaundice. A lot of times you kind of have this fever, muscle aches type presentation. A lot of times this can be obtained, like hepatitis A is maybe a foodborne situation, whereas hepatitis B and C are contracted via blood. Hepatitis C, a lot of times from needle sharing. So none of them are very fun. Hepatitis C can turn into a chronic infection. And that's one that you'll often see, especially a lot of guys from any IV drug users have a pretty high incidence of hepatitis C. And unfortunately, a lot of guys in Vietnam got hepatitis C from one of two ways, either from needle sharing or from getting blood transfusions before they screened for things like hepatitis C. So a lot of people ended up getting hepatitis from blood transfusions, which is really unfortunate. They need to see a doctor. Cholecystitis, anything with a itis is just infection or inflammation of, and cholecystitis is a infection of the gallbladder. Most common reason for this is from gallstones. You have a stone that's made in your gallbladder. It plugs off the exit to your gallbladder, and so then you have a balloon of the gallbladder trying to contract against a plugged off hose. When it does that, all that bile sits in there and it starts to develop an infection. Anything stagnant in the body is not good. So if you have fluid that's pooling in an area, it increases your risk of getting an infection. The gallbladder is no different. So if you have this blockage of your gallbladder, it too can become infected and typically needs to come out via surgery. Some other weird things that can cause cholecystitis besides stones are trauma. You can also get acalculous cholecystitis, which we typically see that in very sick people that have been hospitalized for a long time. A lot of stress on their body. They may be getting their nutrition through an IV, which is a huge risk factor for developing that. But you have pain in the right upper quadrant. That's one if you push up in the right upper quadrant. And so especially they have pain after eating a meal, especially a fatty or a greasy meal. So really anything that you can buy pretty much at Lee Canyon. And so these people are going to have sometimes plus or minus fever. It's possible to have pain in that right upper quadrant after eating and not have cholecystitis. You just may have we call it biliary colic, where you get pain after you eat, but maybe that stone is not completely plugging off the duct. So you still secrete some bile, and it's not infected at that point. But Usually it's relatively painful. All right, bladder infections and pyelonephritis is an infection of the kidneys. So this is very rare in males because for multiple reasons, you have a longer urethra. It's not as close to an area where there's high concentrations of fecal matter. And yeah, for those reasons, typically men don't get bladder infections as frequently as women. Burning when you urinate, maybe some blood in the urine, fevers, going to the bathroom very frequently, things like that make you maybe suspicious for that. Basically, they need to get a urine study done and maybe need some antibiotics if they do have an infection. The issue really here is if someone has you can get very sick, obviously, if you have an unrecognized pyelonephritis. This is more common in older people that don't really recognize the symptoms that early. We often see people come from nursing homes that have, they just come in for altered mental status, but turns out to be they're septic from a urinary tract infection. It's a pretty common thing. The longer you let it go, the further that bacteria climbs up your urinary tract. So it goes up the urethra, gets into the bladder. You get cystitis, infection of the bladder. It climbs up your ureters on both sides and your kidneys, and then you get pyelonephritis, which is kidney infection. If they look okay, these people treat it as an outpatient with oral antibiotics, but if they're very sick, they may need to stay in the hospital. The issue can be if they have a kidney stone in addition to this. It causes urine to back up behind the kidney stone. And sometimes that can essentially become like an abscess inside your kidney. And that needs to actually be drained typically by a urologist. They put a tube through your back into your kidney and to drain that urine out since you have a stone blocking it off. Yeah, so you get pretty sick from this stuff. All right, this is kidney stone, nephrolithiasis. Stones inside the kidney typically don't cause pain. They shouldn't, at least. You get pain when it goes into the ureter. Then you get pain. Usually you have like flank pain, maybe radiating to the groin. It's not really tender when you push on their belly. A lot of people have had these before, and they're repeat offenders. So you ask them, hey, any history of kidney stones? And they say, yes, this feels exactly like a kidney stone. Most of the time, they probably have a kidney stone. Sometimes if they're big enough, they don't pass on their own and they eventually need to have surgery, but smaller ones usually just pass on their own. It's just uncomfortable in the meantime. Bowel obstruction. These happen for a number of reasons, but typically they need to get admitted to the hospital and either observed or they end up needing to get surgery. Sometimes the most common reason for this is previous abdominal surgery creating scars. Sometimes you can have something called a volvulus where your intestines rotate on themselves. In that case, that needs surgery for the most part. And then, yeah, you have vomiting, you'll have pain and plus or minus bowel movements. But for the most part, these people are going to be relatively uncomfortable. Again, not much you're going to be able to do on the mountain except for get them to a hospital. Bowel perforation, this can be a complication of a number of different things. Ulcers, you can have an ulcer that erodes all the way through your stomach or your small intestine. But essentially, you're creating a pathway for your intestines to spill bacteria and fecal matter out into the rest of your abdomen. And that makes you very sick. So these people get septic. They need to go to the operating room. They get their belly washed out. They get IV antibiotics. It can become a mess. And if your intestines have a hole in them, they have to take out that section of your intestine. And they don't fix the hole in your intestine. They just cut that section out typically. Gastritis, it's pretty common. If you eat a bunch of like hot Cheetos or Takis or whatever, these are usually people that maybe have some discomfort in the epigastric region after eating something, plus or minus vomiting. They may feel nauseous. And then, again, sometimes this can be hard to differentiate between this and cardiac type pain in an older person. So just assume in an older person or somebody with risk factors that it's probably cardiac. And, if it's not, great, but somebody with gastritis can certainly be masking as someone with an MI. So if they have epigastric pain and they're not 20 years old and otherwise healthy, more than likely that you need to at least consider this being a cardiac cause. Esophagitis or reflux, essentially when the stomach acid gets back up into your esophagus and it hurts. Feels like someone's punching you in the chest. People, again, this can mimic a heart attack, or a heart attack can mimic this. So the one that's actually dangerous is not esophagitis, and so you need to consider the fact that even if they're having epigastric pain, this may be cardiac related. You're not going to be diagnosing anyone with esophagitis typically before you rule out some cardiac stuff in somebody with risk factors, at least. All right, peptic ulcer disease. This bacteria, H. pylori, is a common cause of ulcers. Also, if somebody's taking ibuprofen every day for months and months, they can develop quite a bit of GI irritation from that. So that's a common thing. If those can bleed and they can rupture. They can actually create a hole through your stomach into your abdominal cavity, which that can make you very sick again. Typically, you have pain right after you eat with a duodenal ulcer, with a gastric ulcer. You eat something and then you have pain. That's more likely to be in the stomach. If you don't have anything to eat and you're having pain and then you eat and it gets better, it's probably a little bit lower in your small intestine. Those are the most common places to get ulcers. But again, a lot of these things can mimic cardiac problems. So that needs to be your first thought, something that you need to consider. Upper GI bleed. This is some of the most disastrous patients that we get in the ER are upper GI bleeds. Patients with chronic liver disease creates something called esophageal varices, which are kind of friable little blood vessels that get engorged inside the esophagus. And when one of those ruptures, they bleed heavily and they just vomit blood continuously until they vomit all the blood up in their body and then they die. So those patients are typically a complete mess. That will be bright red blood typically, and there'll be a lot of it. The upper GI bleed that maybe is like a duodenal ulcer or a gastric ulcer can cause vomiting that looks like coffee grounds. It'll look like, it's probably the only way I've ever heard of it described and I've ever seen it, is that gives the blood had a little bit of time to digest, but it's not bleeding heavily to the point where you're vomiting up bright red blood. But either way, if you're vomiting up blood, you should probably go to the hospital. We just talked about this. All right, female reproductive organs problems. If someone's pregnant, they can have something called an ectopic pregnancy, which is where the egg implants outside of the uterus. It can be in the tube. It can be, you can even have an ectopic pregnancy in the liver. It's not impossible. That has happened before. Anyways, but it's not in the uterus, so it grows where it's not supposed to, and then it can rupture and cause a lot of bleeding, and you can bleed to death from a ruptured ectopic pregnancy. The ovarian cyst, this is pretty common. You get a cyst on the ovaries. It's normal to have cysts on the ovaries, but when one of them ruptures, it can be pretty painful, and it can also mimic this, ectopic pregnancy. It can also mimic something called ovarian torsion. So pretty much you're not going to worry about ovarian cysts. For the most part, that's not an emergency unless they're of a certain size, which again, you're not going to be able to tell that. The one you want to worry about is something called ovarian torsion, and that's where the ovary flips over on itself and cuts off the blood flow to the ovary. A large cyst can be a risk factor for getting ovarian torsion, although it's not, absolutely necessary. But that can create some issues because you can end up losing an ovary if it doesn't have adequate blood flow for long enough. PID is typically caused by an STD that starts to spread up into the pelvis. This can also make you very sick, but this is typically starts to involve the rest of the reproductive organ system. So uterus, fallopian tubes, ovaries. You can get scarring, and this can actually be a risk factor for miscarriages in the future, is having a pelvic inflammatory disease, even after it's treated, because it creates scarring. All right. Again, this can present as a systemic infection, so you can have fevers, severe lower abdominal or pelvic pain, and then maybe some like purulent discharge or something from the vagina. Usually you can't miss it when you're doing a pelvic exam, but you're not going to be doing that. So male reproductive organ systems, testicular trauma this is something you may see, especially if a skier is trying to hit a rail. Snowboarders, for the most part, are, unless they catch it from the behind, relatively impervious to this. But you can have swelling, lacerations of the scrotum. Your testicle may fall out of the scrotum, which I have seen that. None of these things are fun, but really they need to go to the hospital and see a urologist pretty much. You can get testicular hematomas, which may compromise some blood flow. So any testicular trauma probably warrants getting at least an ultrasound and a better exam down at a hospital. Torsion is exactly the same thing as ovarian torsion, except for it happens with your testicle. It rotates and it twists the spermatic cord, which also contains the blood vessels, to the testicle. So about 6 hours, again, same amount of ischemia that any of your limbs can handle. The survival rate of that testicle drops off dramatically after 6 hours. So this needs to go to the operating room. There are ways that we try to detorse this manually sometimes in the emergency department, but that is not something that I would recommend doing on your own. Acute abdomen, again, the acute abdomen essentially means that somebody probably needs to go to the operating room. I don't know, gastroenteritis I would not really consider an acute abdomen. Typically when we say acute abdomen, we mean someone has like a rigid or peritoneal abdomen, and typically that is going to require some sort of like operative intervention. You can get acute abdominal pain from a lot of different stuff, but saying, oh, this patient has an acute abdomen, typically refer to somebody that needs some sort of intervention done, whether that's surgery, admission to the hospital for antibiotics and observation, but mostly surgery. Peritonitis is when you get inflammation of the peritoneal membrane, which is the kind of inner coating of your abdomen. That layer, once that gets inflamed, your belly gets rock hard. Or the other thing you can look for is something called rebound tenderness, where you push slowly on their belly and then you let go really quickly. And if they have a lot of pain when you let go, that can be something called rebound tenderness, which is concerning for a peritonitis. Peritonitis can be from a whole bunch of different stuff. It's really just infection or inflammation of that peritoneal membrane. And that can be from perforated ulcer, ruptured appendicitis, anything that spreads infection throughout the belly. You can get peritonitis from that. Okay, how to assess somebody with this? again, usually they're going to be responsive unless they have like a ruptured AAA. So you take good history, you can take your sample history, and then ask them all of the OPQRST type questions. And that'll give you a fair amount of information that you need to know to narrow down your differential diagnosis on what you might think this is. And then, yeah, so again, none of these symptoms are necessarily specific for any one disease. The ones that I will tell you are the worst things to have are probably this, this, and like peritoneal symptoms or rigidity or rebound guarding. Hematochezia, this is bright red blood coming from downstairs. This one, if you obviously have a large amount of bright red blood coming up when you're vomiting, that's very life-threatening. And melena, which is digested blood, it comes out looking like tar. That can be a sign that someone's having a pretty significant GI bleed as well. Either way, these patients all need to go to the hospital. Okay, so I think everybody knows what vomiting is and what diarrhea is. I'm not going to explain that to you. Oh, constipation is when you can't poop, in case none of you were aware of that. Let's see. Okay, kind of already went over this stuff. Sometimes it may be more comfortable for them to put their knees up, kind of in a flexed position. That way there's a little less strain on their belly if they're laying flat, that is. Okay, so look at their belly. If it's like really distended and it's not just fat, then that can be a sign they have a belly full of blood or something else if it's distended. And then another thing you do that, is pretty, like, you can't fake this type of thing, is if someone's laying on the bed, you kind of come up and you shake the bed a little bit or kind of hit it with your knee, and they have intense pain with that. That's in their belly. That's not a good sign. So they're going to have a fun ambulance ride, but that's probably a sign that they are what we call they're peritoneal. So they have peritoneal signs indicating some sort of severe intra-abdominal pathology. Okay, so you can push on all the spots. Don't, yeah. Even if you think this person has a AAA, there's no reason to not do an abdominal exam. Like that other slide said, no one's ever caused a AAA to rupture by doing an abdominal exam. So don't worry about that. It may hurt when you push on their belly, but that'll give you information that can potentially help you or someone on down the road that you pass this patient off to. Okay. All right. Again, kind of gentle pressure. Again, if you release your hand quickly and they have a lot of pain, that's called rebound tenderness, and that's a concerning finding. What are you going to do with these people? It's pretty much nothing. Try to get them into the most comfortable position. Obviously, if they're unstable, start back at your ABCs. If you're ever lost with anything, you can always start back at that. If somebody's really sick, it can be very scary, especially if you're not used to being in that kind of scenario. But if you just kind of revert back to some basic stuff, you'll be okay. But most of the time, it's just about making these people comfortable. And then if they need to take an ambulance to the hospital, great. If somebody's just had a couple episodes of vomiting and they have a buddy that can drive them, probably don't necessarily need to take an ambulance. But yeah, keep them comfortable. Yeah, if they need oxygen, you can do that. Get a good set of vital signs. And then if the patient's kind of reduced level of consciousness and vomiting, that's going to be somebody that you want to use suction. You can put them in a lateral decubitus position, kind of laying on their side so they don't vomit, and then aspirate that back. Oh my God. So, anyways, don't let anybody drink or eat anything, because if in the event they need to go to surgery at the hospital, they might get upset with you if they're demanding that they eat their. If somebody wants to eat their food that they brought, there's a good chance that they're not that sick. But again, I've had people bring them like McDonald's or something to the hospital, like as we're about to wheel them back to the OR for an appendicitis surgery. So you never know. All right. So yeah, any significant amount of pain, they need more evaluation. Usually if the pain is severe, if they are like bleeding from anywhere, if they have debilitating pain or anything like that, they probably should go by ambulance. All right, 25-year-old female, belly pain, put her on a table. She's vomiting, no blood. Okay, she's been feeling crappy since this morning, but decided to come skiing anyways. All right, no trauma, no meds. Okay. Intense abdominal pain. So this could be about 900 different things. But what are you going to do besides probably nothing? So get her in a comfortable position, take her vital signs, get a good history, and then, you know, if she's having severe pain, she needs to go to the hospital. There's not a whole lot to do here initially. But then you examine her, she's pale, sweating, warm. Now it's migrating pain down to her right lower quadrant. She hasn't had a period in 2 months, so there's kind of a red flag. Okay, maybe this person's pregnant. She's got right lower quadrant tenderness, and every bump on the road hurts. And that's like I was saying, if somebody has peritoneal signs, any sort of bump or movement is going to result in severe pain. So this patient's tachycardic, normal blood pressure. Any thoughts on, give me a top 2 differential diagnoses here for this person? Anybody? Yeah, so what is going on with pregnancy? What are you concerned about specifically? Yeah, whoever said ectopic pregnancy, that's probably pretty high up in the differential for this person. Obviously, anything else that goes on down there, appendicitis, ovarian torsion, the things that make me more concerned for ruptured ectopic pregnancy and possibly appendicitis is the peritoneal component to it. So maybe a ruptured appy versus ruptured ectopic pregnancy. But you know, they're giving you this history of last menstrual period 2 months ago. So person may be pregnant, but yeah, either way, you need to go to the hospital. Don't let them eat anything. Try to make them as comfortable as you can, but really that's all you can do. So, okay, apparently she had appendicitis or something. All right, and last one. Get through this. Sorry, this is a lot of big topics in a short period of time. Okay. Oh God. Hopefully you're not having to deliver any babies on the mountain. That would be suboptimal, but crazier things have happened. All right, we're going to talk about pregnancy problems here. Anyways, this is a weird slide, but okay. Women have babies. That's what that says. Okay, this is, I don't understand. Yeah, anyways, you might encounter someone that's pregnant, basically. And women have been having babies for thousands of years, apparently. So that's a thing that you need to. All right, we're going to skip this stuff. Like, anyways, so one cycle every 28 days. This is extremely varied. Some people are regular, some people have are on birth control, some people have no periods. It's all over the place. So that typically though, standard reproductive cycle is 28 days. Usually you start day one of your cycle, you start having a period, you have it for anywhere from like 2 to 7 to 9 days. Everybody's different, but usually about 13 to 15 days after the beginning of your period is the period of ovulation. And the ovary releases an egg, travels through the fallopian tube, searching to get fertilized. If it doesn't get fertilized, it just disappears. And then if it does, then that egg will then implant inside the uterus, and then you're pregnant. Okay, so it implants itself into the uterus. It starts to grow. Your body secretes hormones at that point to prevent you from having a period, so that lining of the uterus can provide a good environment for that embryo to develop. So usually varies. Average age of menopause is like 51, I believe, but anywhere from you can have menopause anytime you get your ovaries removed, early onset menopause, all the way up until your mid 50s. But typically someone who has reached their 60s is no longer able to, doesn't have any eggs anymore. All right, I don't really, 37 weeks is term. So that's just 3 weeks short of like your standard 40-week pregnancy. Anything after 41 weeks is odd. And a lot of times there are issues with the baby at that point, causing it to not leave the uterus. But anyways, before this, their lungs aren't developed that well. So we'll have to give mom steroids to help kind of expedite lung development if the child's going to be delivered early. I don't really know. None of this really pertains to anything that you guys are going to be doing. A lot of times women have morning sickness, nausea, vomiting during first trimester. This is because there is a surge in the hormone called HCG, which is until the placenta develops in the second trimester, this hormone is pretty high in the bloodstream. It starts to kind of drop off during the second trimester, but this is what makes you nauseous and vomit in the first trimester pregnancy is a high level of beta HCG hormone. Right around 8 to 12 weeks, that is like prime neurologic / organ development. So that's the most critical point. Anytime, pretty much everything before 20 weeks is still forming. Anything after 20 weeks, for the most part, is at that point just growing and further developing. But the actual formation of the heart, the lungs, all the organs is pretty much completed before 20 weeks. And so miscarriage is much less likely after 20 weeks. Not impossible, but the majority of miscarriages that we see are prior to 20 weeks. Okay. So anyways, third trimester, you get bigger and the baby gets bigger. And then sometimes the baby's usually head up, and then before you deliver, it kind of rotates and gets head down. If not, then we got issues called a breech delivery, where the feet come out first. That is suboptimal. I don't really know. So this is important. This is, I feel like, the only thing that anything that's before 20 weeks and probably before 24 weeks is considered not viable. 24 weeks is about the very earliest that you could theoretically deliver the baby and have it live. Although that's not a guarantee. But this is the point where you might start to be able to feel the uterus on exam. So any 1 centimeter above the uterus, you can measure and kind of determine how far along they are by how high the uterus is able to be felt above that pubic bone. But usually at 20 weeks, it's right at the belly button. So anybody before 20 weeks, I mean, there's nothing that you're really going to be able to do to, if they're having pregnancy complications, there's not much to do there. For the most part, what happens is going to happen no matter what you do. There's some physiologic changes that happen with women during pregnancy. Typically their heart rate speeds up a little bit. Usually their blood pressure is a little lower, which is normal. The things that you don't want to happen are for, especially in the 3rd trimester, if the woman's blood pressure is very high, that is and can be an emergency called preeclampsia. So obviously we just talked about this ectopic pregnancy. It's when you get a pregnancy outside the uterus. A lot of times it'll rupture and you can bleed to death from it. That needs to go to the operating room unless it's very small, it's unruptured. Sometimes we can manage that by giving them a medication. All right, again, yeah, I already said all this, apparently. Placenta previa, this will typically present with painless vaginal bleeding. This is when the placenta forms over the cervix. So the baby has to go out this way, but there's a placenta in the way. This is a high-risk pregnancy, and these babies have to be delivered via C-section. Trauma can result in something called uterine rupture. You can also get something called abruptio placenta, so a placental abruption, essentially where it tears a piece of a placenta off of the uterus, and that can create bleeding. And if it's a large enough section of the placenta, it can actually kill the baby since its blood flow is compromised. Uterine rupture, I've seen one of these, and you can actually see like parts of the fetus through the mother's abdominal skin, which is crazy because usually this is like car wreck. A lot of times this will happen when you have a seatbelt that's kind of underneath your bump, and that seatbelt squishes the uterus really hard, and it kind of pops from the top, and then baby comes out. It's not good for anyone. These are the patients that a lot of times we end up doing something called a perimortem C-section, like doing CPR on the mom while doing a midline incision to try to get the baby out while we're doing CPR on the mom. Those are always the worst. Oh yeah, just talked about this. So you get rupture of your, so this is when people say their water breaks, really the sac around the fetus will rupture and the amniotic fluid will come out. This is a sign that they're probably about to deliver, and they should deliver soon after this, because the longer you go with your membranes being ruptured without delivering, the risk of infection goes up pretty significantly. All right, preeclampsia. This is when you get high blood pressure after 20 weeks. Usually it's much later than that. A blood pressure of 160 is relatively concerning in a patient that's very pregnant. They may start to get swelling. They will get protein in the urine. The protein in the urine is the reason they get swelling. And when you urinate out too much protein, your blood no longer have that oncotic pressure inside your blood vessels, and you start to get fluid leaking out into the tissues, and that causes swelling in the face and the hands. So the other important thing about any pregnant trauma patient specifically is that you need to try to take any weight off of their inferior vena cava. What you don't want to do is compromise any blood flow trying to come back from the legs up into the heart. So what you do is you kind of lean them. You can put like a couple pillows or some sheets underneath the right side, and have them kind of lean over to the left side. That way you shift that weight off of the vena cava and more to the left side. That's a pretty important thing as far as trauma patients that are pregnant. That can help a lot with blood pressure issues. So people with gestational diabetes, I mean, I don't know how much, if you do a finger stick glucose and it's extremely high, and the patient has no history of diabetes and they're pregnant, this may be what's going on, especially if they're having some vomiting, not feeling well. Either way, they need to go to the hospital. All right. So, yeah. So typically, getting a good history is key to figuring out what's going on. If somebody doesn't, I mean, probably half the pregnant women I see tell me that there's no chance they're pregnant. So if they're sexually active and they are not taking birth control, not using condoms, etc., they can be pregnant. Anybody, regardless of what they say, under the age of 50 can be pregnant if they're sexually active. So people will tell you lots of stuff, but a lot of times they are either lying or oh, I forgot about that one time. So anybody, you need to consider this, any female under the age of like mid 50s probably, especially with abdominal pain or any sort of like vaginal complaints. If somebody is coming to the ski resort at 38 weeks pregnant and having contractions and decides they want to stay there and deliver their baby, then Godspeed. I don't know what to tell you there because I don't know. But a lot of times it'll happen on its own. Any pregnancy-related complications during birth are not easy to manage typically. These are issues that OBGYNs train for 4 years to learn how to manage. So, do what you can. Catch the baby, don't drop it on the floor, and make sure you get that person to the hospital as soon as possible. Why we're talking about this? Okay, it's the same thing as before. There's not really any reason to do a GU exam. I typically take patients at their word. Hey, I'm having a lot of vaginal bleeding. I'm not one to say, okay, prove it. But either way, you shouldn't be doing that on the mountain. So if you can feel a uterus above the belly button, that's a sign that they're probably above 20 weeks. And you can see if they have any fetal movement, although this isn't going to change anything that you do. You need to get them. The patient would be better off delivering the baby in an ambulance, probably, at least on their way to the hospital, than on the floor of the dining facility. So the sooner you can get this person on the way to the hospital, the better. At least we do have clamps, and we have a little OB kit, so that way, if absolutely necessary, that can happen. But ideally, that will not happen at the resort. Again, you got to be prepared for anything, but that's the one thing. If the baby's out already, great. You can kind of rub it, try to stimulate it a little bit, get it to cry a little bit, and otherwise just more supportive care. Wait for someone to get there. The one issue can be is the umbilical cord. If you leave it too long, sometimes it can drain a little bit too much blood from the mom, and they start feeling a little woozy. But again, not the end of the world. If you decide you want to do nothing, you don't want to clamp it, you don't want to cut it, totally fine. The patient's typically going to be okay, even if you leave the umbilical cord attached. Typically, the body will try to get rid of that placenta within 15 minutes to an hour after delivery anyways. You can have a lot of bleeding during pregnancy, especially in delivery. Really the only thing to do in this scenario, and this is for me in the ER as well, If someone is having a ton of bleeding like that, usually the only thing that I'm able to do is either give them TXA or pack the uterus, and they need to go to the operating room. So that's a pretty significant problem. That's a very common reason for death during childbirth is a significant amount of bleeding. So do all the things that you would do for any other trauma patient, except for, again, this is the same deal where if the patient's still pregnant, they need to be kind of on the left side to try to unweight the uterus off of the inferior vena cava there. So oxygen, rapid evacuation, and then they need to get to a definitive facility, especially when there's trauma involved in a pregnancy. All right. People tend to bleed a lot after they give birth. Again, left side. This is going to be the one thing that you can do if someone does deliver a baby on the mountain. You can provide some uterine massage where you basically take two hands right on the top of the uterus and you just kind of rub the uterus. Basically, this will help the uterus contract down and stop bleeding so much. This is actually, even if somebody comes to the ER and they have a lot of bleeding, this is the first step. This is the first thing we do. And this is something that's very easy and that you can do anywhere. If someone's just delivered and they're having a lot of bleeding, you want to get that uterus to clamp down a little bit faster, and you can do uterine massage. So don't put straps over the pregnant belly. These are uncomfortable to begin with, but if you must immobilize a pregnant person, again, try to stick something underneath their right hip. Okay. All right. Oh God. Okay. 3 stages of labor. Contractions gets more frequent. Cervix dilates. Baby comes out through the birth canal. There's like a bunch of positions they go through, but typically the head is facing backwards first, and then we'll turn to the baby's right side, facing the mom's right leg, and then the rest of the baby comes out that way. Shoulder will pop underneath the pubic symphysis. If that doesn't happen, that's something called a shoulder dystocia, which is a fairly common but scary complication of pregnancy, and that's when the shoulder essentially gets stuck. A couple of things you can do: try to get their legs further back. You can put some pressure up above that pubic bone. Try to kind of push that shoulder underneath it. But these are pretty scary, and this is something that I really hope that you never have to deal with on the mountain. But again, shoulder dystocia, just extreme lithotomy position. Put their legs back as far as you can go. Put a little pressure right above the where you think the shoulder would be, and then some kind of downward traction on the baby's head. 3rd stage of labor, deliver the placenta. That's not the most critical step. You can clamp the cord. So basically what you do is you clamp on both sides and you cut in the middle. It's fairly simple. It's may have a little bit of blood that's trapped in the middle of those two things, but again, that's a relatively safe thing to do. Just if you cut the cord without clamping it, mom or baby could bleed to death. So I would not recommend doing that. And then delivery of the placenta, you just kind of put some gentle traction on it for a few minutes. A lot of times it can take a little bit longer, but again, this is not like a priority. Mom and baby are the priority. Delivering the placenta at the ski resort is low priority. Okay, this is when you get kind of what's called a mucus plug. That's a little bit of blood in it. That will come out. That's what's plugging up the cervix when someone's pregnant. And then you get your water breaks. if it is a weird color or smells bad, then that can be a sign that the baby has actually pooped in there, and that can be a problem when they're born as far as breathing goes. Because if they aspirate that stuff, that can really mess up their lungs. Yeah. Okay. This can be a big problem. This is how people end up with their hand up someone's vagina and having to be wheeled to the OR in that position. So the cord comes down first, and the baby's head compresses it, kind of cutting off its own blood flow. So what typically needs to happen, don't push, need a chest position. And typically what we do with this is we try to elevate the head off of that umbilical cord. And then the patient goes, like, you can't, once you do that, you cannot move. So that patient has to be wheeled to the OR. And if you are the one that has decided you're going to elevate the presenting part, you are then stuck in that position until the baby comes out via C-section. I fortunately never found myself in that scenario, and I usually have somebody else do that so that I don't get taken away for an hour from the ER. Yeah. All right. So yeah, if the person's going to deliver, you got to try your best. It's obviously not an optimal scenario. But again, remember, this is women have been doing this without anyone else's help for thousands and thousands of years. So it's no guarantees that something bad is going to happen. But you know, if it's going to happen, it's going to happen. There's not a whole lot that you're going to do to stop someone from delivering that is about to deliver on the mountain. So do the best you can. I think you got some pictures on what to do here. If there's a lot of bleeding, uterine massage, keep the patient laying down, oxygen, take their vitals. Again, get them down the mountain as far as possible, or as fast as possible, and then you can pack the perineum and the vagina if there's a ton of bleeding with gauze that we have in your packs. Okay, so you want to stimulate the little baby. That means essentially rub it with towels and stuff. Try to get all the cheese off of it, and then if it starts crying, that's a good thing. You may, if you have we have a little bulb suction, kind of try using that, suction out the airway if the baby's having a hard time breathing. Make sure the head, this is obviously after the head is delivered, you want to do the suction. That way they have a little bit easier time breathing initially. Yeah, you can flick the bottom of their foot to try to get them to cry, because what the crying does is it like pops their lungs open for the first time. So the crying creates a lot of pressure in the lungs, and it opens the lungs up. You're not trying to be mean. You have to get the kid to cry to open the lungs up. And whether that's from drying them or you can just flick the bottom of their foot to get them to cry, then do that. If they don't cry and they're not breathing, then you got a problem. Then you got to start doing rescue breaths. The majority of kids will code because of respiratory issues, and that the vast majority of any neonatal resuscitation is primarily respiratory focused. Unless the kid has some sort of like congenital heart abnormality or whatever, by and large, if you are able to appropriately resuscitate the airway, the pulse will come back after that. I have unfortunately had 2 of these in the last 2 weeks, newborn codes in the operating room that I've been called up to, and both of them were primarily respiratory issues. So once we get the airway established, once we get breathing for the baby, even if they've had a few rounds of CPR, maybe got some epi, they typically will come back once you get their respiratory situation squared away. Less than 90 beats per minute, you want to give some positive pressure ventilation with the bag valve mask, with the baby adapter. Yeah. So you don't want to give huge breaths with a baby, but you want to give, about one breath every 1.5 seconds or so. If the heart rate is less than 60, that needs CPR. So that's a indication to start doing compressions on the baby. And that's, again, the way you do that is you basically take 2 thumbs right over the middle of the chest and you just squeeze them like that. Okay, this is a very good indicator of if you have a baby that comes out and it looks gray or blue, that's not good. If you rub it down with a towel, it starts crying, it pinks up, that's good. If it doesn't do that, it doesn't start crying, then that's a situation where you need to start giving some positive pressure ventilation with 100% oxygen. And then obviously you want to get a pulse. And if it's below 60, you got to start chest compressions. If it's above that, keep doing what you're doing with the airway, and hopefully their heart rate will follow. Yeah. Yeah. Again, a lot of babies are blue when they come out, but if they're blue and floppy, that's not good. Okay, we already talked about that. Yeah, squeeze the baby like that. You got to go pretty quick on a kid. It's still about. You can do the abide by your ACLS protocols or PALS protocols, and then yeah, do CPR until that heart rate gets above 60. They still need CPR because a baby's heart rate of 60, while that might be fine for you and I, that's not pumping enough blood to keep their organs alive. Yeah, never end a resuscitation of a child unless you are like, you're the one providing the definitive resuscitation. If you are any sort of pre-hospital setting, there is basically no scenario unless there's like obvious signs of death that we have protocols for, that you should discontinue resuscitation of a newborn until they get to the hospital. Yeah. So keep the baby warm. That's the most important thing here. Get some blankets. They're pretty susceptible to temperature drops, so you gotta keep them warm. That's like the primary objective if they're doing well. You don't need to figure out the APGAR, but low APGAR means they don't look very good, and you may need to do something to help them. This is a scoring system that we do at 1 minute after they're born and 10 minutes after they're born. And usually you want your score to be 10, but it's not always. 8 and 10 is pretty good. 0 is obviously bad. But this is, it's kind of, if you look at the kid and it doesn't look good and it's not breathing and it doesn't have a pulse, then you don't really care what the APGAR is. You're going to start doing your PALS on it. All right. So sexual assault, you see, unfortunately, quite a bit of this in the emergency department. This can be a wide variety of things, even just from, typically sexual harassment does not necessarily involve physical interaction, but sexual assault typically does. And so that's any sort of like trauma, whether that's can be any gender on any gender, any age on any age, and anybody under the age of 17 or 16 with an adult cannot consent to anything. And then different states have different laws as far as consensual age with other minors. So that is not something that you're going to be worrying about. But if someone has trauma, then that's going to be something you're going to be worried about. All right. Yeah, so you got to report this stuff. This is a mandatory reporting event. If the patient absolutely does not want you to report something, that's kind of a difficult situation. You're somewhat obligated to. it doesn't matter what the patient says if they're under the age of 18. So that in itself, you have to report this stuff basically. Yeah. So this is like take care of them as if they're a trauma patient, except for they're going to be probably a lot more. There's, physical trauma, but there's also quite a bit of emotional trauma that goes along with this as well. So it's kind of a delicate situation. So a lot of these people, this is an embarrassing situation. They don't want it to necessarily be any sort of like publicized, try to get them to somewhere where there's nobody else around. It's not, this is more of a sensitive situation on multiple levels. So yeah, as long as medically they're doing okay, then that should be obviously your first priority is medically okay. And then second priority should be kind of respecting their privacy and confidentiality, and then also figuring out what the best way to move forward and report this, whether they need to go get a sexual assault exam at an emergency department and have, all the kits collected. And that's actually going to be up to the patient. You can report it, and then the authorities will obviously contact the patient. And if they don't have any desire to go to the emergency department, they don't want to report it, they don't want to press charges, then it's not a jail. You can't necessarily force somebody to do any of that stuff, although you can give them reassurance, but that's about all your role is going to be in this situation. So anyways, here we go. Let's see. Okay, this person is having a problem. There's a 29-year-old, half naked, a lot of blood on the floor, screaming, severe abdominal pain. She is lots of blood clots in the toilet. She's got a thready radial pulse and is tachycardic. Okay. That's maybe like a pretty basic thing that you can do for this person. Maybe have them not stand to start off with. So you get them more of a position of comfort. And then, this is somebody that you want to get 911 called as quickly as possible. And then you want to determine early on if you can grab a set of vitals on this patient. Is their blood pressure low? And maybe why are they bleeding? So your big decision point here is this person pregnant or not pregnant? They're of age, so you may want to assume that they are pregnant. Typically in premenopausal women, any sort of pregnancy-related issue is the primary cause of hemorrhage, like vaginal hemorrhage. Okay, so she wants you to help her. You put her on her back, several blankets. Heart rate's 112. Okay, great. Okay, great. So she's still bleeding. She still has clots. Vitals are stable. They get there. They put an IV in. This is a lot of words, but not a lot's happening. Okay. She was 3 months pregnant, had a miscarriage. Okay. Yeah. I mean, there's not a whole lot that you guys are going to be able to do in this scenario. Obviously, you need to identify the patient is sick and is bleeding. Get them to a comfortable position. If it's a trauma scenario, you can put them in the kind of left leaning position, but really the only thing you can be able to do for this person is to just get them to the hospital as soon as possible. Not much on that one. All right. I don't know. Oh God. Yeah. So this is fun. Voila. That's all there is to it. Okay. I don't, okay. There's he pulling the placenta out. All right. I don't know if any of you have ever done this, but it kind of, for the most part, it does it all itself. Really, the only thing that you should be focused on is not dropping the baby from a height onto the floor. Usually what I like to do is you can kind of this might sound weird, but you kind of get the baby on the back of the neck like this when they're coming out. Because if you try to hold onto their head and they're very slippery. But once you get the head out, you kind of flex it down and the rest of them comes out. You want to get your hands kind of around the back of their neck. And then the other hand underneath them, and that'll prevent you from dropping the kid. So, I mean, yeah, this is, you can review this on your own time. But I think that's all I have for you. Yeah, great. Okay. So a lot of words, a lot of steps. I don't think I probably didn't get good at this until I did like 15 of them. So if you have never done this before, then this is probably not going to be something that you're going to just, snap back to this type of training. So anybody have any questions about this or anything cardiovascular? This is obviously a massive 2 topics to cover in a short period of time. So I'm not going to be surprised if you don't retain a lot of it, but hopefully this has been somewhat helpful.
You did great, Taylor. Thank you.
Yeah, no problem. Thank you. All right. Hopefully I saved you from a Wednesday night pre-Thanksgiving lecture. So I'm doing your trauma thing on the 30th, I think. So I will see. I'm going to try to spice up some of these PowerPoints, maybe with some cool pictures and stuff that I have. So that way it's not so dull and full of words, because pictures are way better and more exciting. So especially for the trauma stuff, I got a bunch of good ones. So, but yeah, if nobody has any questions, then I guess we're done here. And
two quick questions.
Yeah. All right. Go for it.
An AED, if it detects a VF or VT, it'll shock. If there asystole, if there's nothing,
yeah,
it does not, right? I mean, that's
correct. Yeah, you do not shock asystole. The idea being, if there's not really any electrical activity to begin with, you're not going to really restart the heart. It's when you have electrical activity that is kind of out of control, the idea behind defibrillating somebody is to kind of reset that electrical activity. If you don't have any to begin with, then defibrillating it has not been shown to be beneficial in that scenario. So that's just a straight CPR for asystole.
okay.
Yeah, or what we call PEA, which is, you may see some electrical activity, but it's not like a definitive VFib or VTAC. For that, it will not shock either. So those are the two that it's not going to pick up really.
Okay. And then one more, if you're doing a abdominal exam, does rigidity feel different than like distension? In other words, does the skin feel hard as opposed to a distended abdomen?
So the skin doesn't necessarily feel hard. If you have somebody that has a distended abdomen, that can be from a variety of reasons. Most people, if it's truly distended, and it's not just that they're fat, it will, for the most part, it'll be relatively rigid as well. If they have if they have tons of bleeding into their abdomen, they're both going to probably be distended and rigid. Most of the time, if you have a very distended abdomen that's from some sort of perforation, rupture, bleeding, it's also going to be, you're also going to have rigidity, but just because your belly is rigid does not necessarily mean it's going to be distended. So you may see a skinny 16-year-old kid with a ruptured appy, and his belly is hard to the touch, but not distended at all. That's a pretty common thing. Usually the other way around, we tend to see truly distended abdomens are also hard to the touch. One exception to this, though, maybe important, is somebody with cirrhosis. They tend to get this ascites, which is basically like backup of peritoneal fluid in the belly. That will be a distended abdomen, but it'll feel like it's fluid filled. They're not going to necessarily be rigid. So that's one instance where you can have a distended abdomen, but not necessarily a rigid abdomen. So,
Okay.
Yeah.
Okay. So there's no class on Wednesday. I'll send out the test. If you have any questions, just jot them down and we'll see everyone on Monday. And thank you, Taylor.
You're welcome.